are live here on the 9th episode of the LA Shoulder Podcast.
Okay.
With me today, where we sit shoulder to shoulder with the experts. With me today, I have my good friend, Jazz, Dr. Jazayeri, and my also good friend, Gray Hunt. Thank you guys for coming on my show.
Thanks for having us.
We are live.
Thank you. Great to be here.
All right. So this is the second time we've been on together. The first time I just was kind of learning about XR, and you're the guy that, you're the founder of the company, and you're the formulator for XR. So I want you to talk about that a little bit. So now we're having kind of some discussions regarding musculoskeletal infection conference that was taking place in Turkey, and that was international, right? So it's an international consensus meeting.
Yes.
So that's what I really wanted to talk to you about when we got to have you back on the show, because XR was so great, and there was whole different pockets where we could talk about just infection. So I kind of wanted to start there.
Sure.
But also we were going to talk about a little bit about like optimization and using XR as a performance supplement. But let's talk about the meeting. So you guys both went to that meeting, right?
Yeah, that meeting was incredible. You know, all credit to Dr. Parvizi, who really masterminded this meeting. This is a meeting, the ICM International Consensus meeting on specifically infection. This was an incredible gathering. Over 1,000 delegates.
1,000 delegates.
Yeah, they were invited from over 100 countries.
Uh-huh.
And it just goes to show you the importance of infection and how devastating it is to all our patients. I mean,
Well, so it was an infection meeting, but it was it infection in terms of just orthopedic infections, or was it
strict orthopedics,
human
Joints.
infections? Okay, so it was
Joints.
joint infections.
hip, knee, shoulder,
Okay.
right? And the things that we stress about, right? I mean, that's the one thing I would say of all the complications that we have must be the one that keeps us up at night, most devastating, right?
Uh-huh.
So this is a very common issue that we all face.
Infection.
Yeah. I mean, we see it, right? And so the meeting was, what can we do to come to a consensus to agree on what are the best practices? And this meeting meets every 5 years, because it takes 5 years to kind of collect all the data and what's the latest and greatest, and what can we agree on that we should all have a consensus on how to best approach our patients from beginning to end, treatment, prevention, and treatment.
They've been working on this meeting. How many meetings have they had?
This I think was the third one.
Third meeting, right?
Yeah.
And the last meeting was
They were in Philadelphia.
Right. Well, it was when I was a fellow, I think.
Yeah.
It's when we had a delegate there.
Yes. Yeah.
And that was 2019, I think.
So it was, every 5 years they meet.
Every 5 years. So now it's the 2024 meeting,
Mm-hmm.
right?
To 25.
Oh, it's a 25 meeting.
Yeah.
Okay.
So
Which months did you go there?
we were there in May.
And which part of Turkey was it? Istanbul?
Istanbul. Yeah. It was incredible. It was beautiful.
How long did you guys stay there?
It was about a week. Yeah, about a week. We took an extra couple of days to just kind of enjoy the city.
Yeah.
But the meeting itself was really, it was very unique, because you have all these surgeons from all over the world, and they're all very passionate about this. I was very fortunate to be chosen as one of the delegates to, contribute. But,
Yeah.
I learned way more than I contributed. This was really an incredible meeting. And having all these surgeons kind of sit in one auditorium, essentially, and everyone's given a voting. And you're presented the data, which the experts will present, and then you get to vote if you agree with this. And so the questions are brought up. The questions were brought up 3 years ago.
Polling the audience, right?
Yeah, the questions were brought up 3 years ago.
But the audience is specialists in,
Yes.
in infection and in treatment of orthopedic injuries.
And what was interesting is it wasn't just orthopedic surgeons. The other very passionate group about this were the ID guys. So there was about, I don't know the exact number, maybe 20-30% of the group were infectious disease specialists. And, we rely on that profession heavily when we have an infection. So basically, we got, I was involved with that because there were two specific questions specific to nutrition. Infection, we talked about everything under the sun that you can think of, wearing spacesuits, antibiotic regimen, duration of antibiotics, steroid use, anabolic steroid use. I mean, anything you can think of, obesity. And so the two questions that were presented that had to relate to nutrition, the first one was, should all our patients who are going under arthroplasty, should they be screened? Should everyone be screening for nutritional status? And if you put one case in front of 10 orthopedic surgeons, you're going to get 10 different answers, maybe 11 different answers, right? No one can agree. This is the way orthopedics is. We all have our own ways of doing it. But what was really interesting is over 80% agreed that we should be screening based on all the literature that was presented. So that was really compelling to see that. And this is something that's going to be documented. So if there was not enough consensus or evidence, then there wouldn't be a consensus. And a lot of people would say, you know what, on this particular topic, this question, we don't have enough data. So we rather say we don't know and move on until we get more data.
So that was would you say that was the most important question, was the top?
I mean, that was the most, maybe I'm biased because that was, a lot of things were interesting, but I think as it has to do with nutrition, this was really interesting to see. So number one was, should we be screening? Because that's the first thing. I mean, most people are not even screening. It's not on our radar, right? And then the second question, the follow-up to that was, is there a role for nutritional supplementation to decrease infection and complications? And they presented the data. And then after that was presented, again, over 84% consensus that yes, there is specifically a role for supplementation, specifically protein-based, which is really amino acid, which is the underlying issue. There's a role for supplementation for that as well. So to me, this was really exciting to see that, and not just from the U.S. or any other. It was a global consensus on this. So this is where you start seeing the awareness on this get increased, and I think it's going to take a few years for this to trickle down to our clinical practice. But that was a really exciting meeting for us to see that. Yeah.
So there was a consensus on that specific topic, that not just screening, but actually performing intervention.
Correct.
For patients who would be considered at risk of nutritional problems.
So that's a very interesting point. So,
but people that had an infection with a proven infection.
No. That this is what was really interesting, is that screening should be done on patients who are going to have surgery. Period. Just kind of like thinking, if someone has diabetes, do you check their A1C? We do.
You should know what that is.
We don't question that.
You should know what the blood sugar is.
Right? So we should check that. And the same thing here, when we look at patients' complications, they're so associated with nutritional status, and complications are so high that if you don't screen, then the chances of overlooking something that could be, and here's the key part, this is a modifiable risk factor. It's not like age. It's not like some of the comorbidities that we can't really modify. This is something you can modify, and you can modify it in a relatively short amount of time. So if you screen, then you can pick it up. And that to me is really the biggest thing, is this is something we actually have some control over.
So there was a consensus on screening?
Yes.
And so what was the consensus in terms of, was there any consensus in terms of how they should be screened, or what labs in particular, and who should be screened?
So everybody should be screened who's having a major arthroplasty.
Even as a primary arthroplasty?
Primary, of course.
So they should be screened for nutrition labs.
And this is going to be published soon. This is going to be published.
That's definitely news.
This is very news. We're probably in the next month. This is going to Journal of Arthroplasty. We've been working on this. The group has been working on this for years. The consensus meeting to come to this point is it's been a journey to get here. It's
been total hips.
So hip and knee,
total knees,
total hip and knee were really the first.
Right, but what was included in the consensus?
Hip, knee, and shoulder.
For arthroplasty?
Yes.
Okay, so yes. As a primary.
Primary.
Did they include revisions with those rates, or was that a whole separate category of discussion?
That is these.
So we're just talking about hopefully preventing issues that might lead to revision.
Correct. But I'll tell you something interesting on that point. So we know that nutritional status affects the risk of getting an infection. But the next step is actually interesting as well. Your risk of treating an infection is also associated with nutritional status. So your failure of whether it was a DARE, first stage, one stage, or two stage, all of that was affected by your nutritional status. So your likeliness of being successful in treating an infection was also associated with nutritional status. So basically, if someone comes in with a known infection and you identify the bug, we do our culture, right? And we put antibiotic spacer in, or you do it in one step, whatever way you choose to do it. If you don't check their nutritional status, these patients are not capable to have the immune response in order to beat the infection. So just treating the bug doesn't treat the host completely. So you really got to look at it in a comprehensive manner.
Right, because the host is still, they don't have what it takes to fight because they're already going through the problem itself, right?
Correct.
They're going to go through surgery and have all this, hopefully very precise damage to certain tissues that are just trying to recover. And it takes 3 months for musculoskeletal tissues to recover to bone, soft tissue basically. It takes about 3 months, and that goes through a whole process. And, if you can modify that while they're healing versus break down other tissues and put the body in catabolic stress, right? It's basically you're breaking down if you don't have the right stuff. So your body takes what it needs. It has to have essential amino acids. And so if you're not giving it essential amino acids, it takes them from your muscle in other places.
Your body gets extremely depleted during the course of an infection. And so you take that hit from the surgery itself being catabolic, and then you recover slowly. But an infection is devastating. It really taxes the body.
You're getting a fever. It's burning energy just to heat you up. Your own body is burning that energy to keep you a little hotter the whole time. So it's using up a lot of resources.
You're revving at
It's just one of many.
Yeah,
right?
Yeah. So it's really interesting to see that there's more awareness on this for now as surgeons. Let's look at that, right? Let's not just jump into surgery right away. Let's screen.
Pause.
Right? That's
I
right.
like that.
Yeah, pause. And if you have an infection, that's definitely a time where you say, look, let me identify the bug, but let me also look at the patient themselves. Are they prepared? Can they recover?
Mm-hmm.
And so that's the other aspect is to really look at them when they're infected.
Mm-hmm. Are you screening still everybody that you operate on?
Absolutely. And so we actually kind of expanded on this, and this was something that I was going to talk to you about as well, is, we have these different scoring systems that we like to look at, whether we're talking about like rotator cuff, looking like the Rohe score, right? Looking at some of these ways that we typically classify.
ROHI, it's
ROHI.
like risk of failure for certain parameters in the rotator cuff, right?
The things that
like
we typically
fatty
look for.
degeneration, size of the tear. There's several, but you put a score together.
Yeah, you put a score together,
so
right?
it gives you like a risk.
Right. So we like numbers, right? We like to say, okay, patient comes in, what do we typically do? We look at their x-ray, we look at their MRI, and we take these pieces of information, right? And then we can take that and talk to our patient, say, look, you have a one tendon or a massive rotator cuff there. That's a different discussion you can have with the patient.
Yeah.
Right. But that's only kind of half of it. This is something we focus on. There's another variable. That's the metabolic side. The metabolic side of the patients. This is what gets overlooked. So
that's where the pause comes in. Because a lot of times we can fix it. We're like, hey, you're indicated for surgery, and then you can't see those labs, right? But something might flag you, like, yeah, if you had some issue with healing, or they tell me they don't know any other medications that they take, or something weird, right? So, hey, let's just pause and kind of look into all of the other factors, not just the surgery part of things.
So I would say let's take the rotator cuff. For every shoulder surgeon who's doing a rotator cuff, you're probably going to get an x-ray. You're probably going to get an MRI, right?
Yeah, basically.
So those are your
I call it for surgical mapping, so I can get a picture of,
okay, I like that. Okay.
Yeah,
so let me expand on that.
Mm-hmm.
So now, in addition to that, knowing that you're fixing the anatomy, but you also need to deal with the patient and their actual intrinsic ability to heal. And that has to do with some of the metabolic stuff that we just didn't look at. But now we have a lot of literature that shows there's metabolic variables that are directly and independently associated with healing. So this Metabolic Report Card that we're looking to validate takes into account these variables. Albumin, vitamin D, lipids, A1C, and hormones. So those are the 5 that now I screen on all my patients who come in.
So how do you get those types of labs? If you're going to look at lipids, you get HDL, LDL,
so there's
cholesterol level.
So the lipid profile. So it's a smart phrase you put in. So what I just told you, I have it all in a smart phrase. Men get testosterone, women get estrogen tested. estradiol. If you're diabetic, you get A1C. Everyone gets a lipid panel. Everyone gets albumin and vitamin D.
Is there a metabolic report card? Is that something I can look up on your site, or is that something that you use?
Yeah, that's something that we just written up, and we're looking to validate. We're collecting multi-center studies and looking at that. So if you'd love to get involved with us, if you want to get into that. But
yeah, do you have something I can look up right now?
It may be something online. I'm not sure we have it up yet.
I looked at metabolic report card, but should I look up your name or is there anything published online about it?
I don't know if it's published yet.
Oh,
but,
okay.
We should.
We may not have published that yet.
Seems like something good, even maybe to put on the XR.
Yeah. It's actually it's on the to-do list.
Yeah.
I presented it already.
I thought it was what you were talking about, the macro calculator. That one.
No, that's
I use
different.
That one all the time.
I presented the.
This is more for surgical pre-op, making sure the labs are.
Yeah. So I presented this recently at AOSSM.
Look normal.
The Sports Medicine Academy, the Sports Academy meeting, this metabolic report card, and it was great. We had a lot of good discussions about it, and it really stimulated a lot of good conversation and different institutions getting involved in collecting data. So yeah, this becomes something that now when I see one of my patients who's got a rotator cuff tear, I look at the X-ray and the MRI, and I look at their metabolic report card. So I sit with them and I say, look, you have this much arthritis. Your rotator cuff tendon looks like this. And then you have this metabolic report card. Where are you? Where's your albumin? Where's your vitamin D? Where are your lipids? Where are your hormones? And each one of these have been independently shown to have an impact on healing and repair.
Hormones being thyroid, TSH?
No, specifically. So we only included things that there's literature on. So for men it's testosterone, and for women it's estradiol. And
then would you say, do you have ranges that you classify as normal, highs and lows?
So that's one of the challenges. So the range of normal is pretty wide, okay? And this is actually out of Utah, Bob Jane's group. They've done a lot of work on looking at these metabolic values. And it's interesting to see when they looked at all the variables that I just told you, they actually didn't look at nutrition, but they looked at all the other ones. What percentage of patients do you think were normal, had no abnormalities?
That had no abnormalities. Yeah. Probably a small percentage. I bet it's more common to have something abnormal. And then the doctor says, oh, it's just because of lab abnormalities or something like that.
6%. 6% were
single digits
without any issues. That means we have 90+% of patients that we can optimize and lean on, whether it's vitamin D, whether it's albumin, whether it's their hormones, whether it's their lipids, their A1C, right? And so to me, this is where the pause is really important, because you and I can do a rotator cuff repair in our sleep. That's not the hard part. That's the fun part, right?
Right.
But dealing with a re-tear or a patient who's still got some pain, and you're like, do I want to get another MRI 4 or 5 months after surgery?
What can we do to get it to heal? We want to optimize the healing.
What can we get it to heal?
Yeah. Good outcomes.
Good outcomes.
That's
right?
What I'm all about.
Right.
How do we get a good outcome? Everybody wants that.
Right. And I think this is where, as surgeons, we're now starting to kind of think outside the OR. We're like, because look, we're control freaks, right? We want everything to be done, right? That's what we have to be. But no, we have. It's our job. It's our job, right?
What do you think, Ray? Control freak?
Absolutely. Yeah. I think, but in the best way possible, that it should be your job to control the environment for your patient and optimize that to get the best outcomes.
Yeah, but is Reza a control freak? That was what I was asking.
There's some things I don't want any control of, and certain things I do. So,
but yeah, that's why it's like, he's looking at these things in a similar way until he finds, how do we get optimized, right? So it's like, how can I do those things? Is it possible? If you never found out it was possible, you probably would have given up. You would have said, oh, there's some kind of formula that maybe I just can't understand, or maybe there's not a formula, but you found the one that seems to work pretty well based on studies, based on science. And so you start off with a good product. That's what I love about all these studies that you've been talking about, is because we're talking about the screening as the literature starts emerging, to show what are the factors that were pretty responsible for malnutrition. It was definitely, you said earlier, albumin was one, prealbumin, I think you said it
Yep.
earlier. And then there were some other factors. If your labs are off, or the ones that you were discussing, the albumin and the lipid profile, those are the ones that we're still looking at, that you're interested in finding specifically. Can we formulate a protocol that will define malnutrition, right? I mean, that's really what it's looking at.
So, I
Because
mean,
we just have more loose data and these big studies on like albumin, pre-albumin, but not a lot of protocoled studies looking at malnutrition.
Right.
And
I'll tell you,
defining
I almost want to stop using the word malnutrition because I think that is
abnormal
misleading.
nutrition.
I think,
What do you want to call
no,
it?
I mean, I think it's just looking at someone's nutritional status, because I think there's a spectrum, right? I think there's a spectrum on nutritional status. So I think for me, I mean, when I hear the term malnourished, I'm thinking of someone who is in a third world country, or someone who's in the ICU, someone who's totally cachectic and you know is in a different kind of, is in a different mindset and a different physiological condition than my patients who are walking in the operating room, right? But 40-50% of our patients are not nutritionally optimized. So I think that's another better way of looking at it. I mean, the recent Japanese study, the JBJS 2024, 66% of their patients were not fully optimized and had a 5.6 times higher retear rate. I mean, that's significant. That was much more impactful than the size of your rotator cuff tear or the atrophy. So again, that goes to tell you the patient's intrinsic ability to heal is definitely more important than which anchor you use or which sutures you use.
Yeah, the soft tissue problem.
The soft tissue problem, the soft tissue in the bone, the musculoskeletal, right? So you got that. This is where the lipids and the vitamin D and all these variables, it's very complex. And so, we don't have all the answers. We don't have we don't know everything right now, but at least we got to dig deeper.
So with that protocol of your malnutrition protocol, I guess I'll just call it that, metabolic.
Or optimization protocol.
It's more of an
It's an optimization
protocol.
yeah.
So you might, with that, you have a higher level of sensitivity to find somebody that's not perfect labs. So that way you can kind of identify, we got to be ready to go with perfect labs before we do surgery.
Yeah.
So that's gonna weed out people that aren't ready for that level of optimization.
Completely.
So then the next question I was going to say is, how do you look for correction?
Oh yeah, so absolutely. So I think
the correction of the labs, and how long do you give it to find that correction? As long as it takes.
So just to back up 1 second, I think the nutritional component is one aspect of the metabolic thing. So I think the metabolic is the metabolic window is what we're looking at, the umbrella. And I think nutrition is one aspect of it. So I think the hormones are the other aspect. I think the vitamin D with the bone, aspect of it is a different one. And so I think these are all different kind of areas that we can intervene. And so when I see somebody who's indicating for surgery, when I schedule them for surgery, I also pull the trigger on these labs. So these labs automatically get done. And when the labs come back, that's when I look and I say, okay, look, where are you on this? And so if the vitamin D is super low, I'm holding off. I'm telling them, look, if your vitamin D is...
Why would you proceed if it's not abnormal? Yeah, I mean, if it's abnormal.
I mean, right?
Makes sense. But that's what you would think too. But if we're not checking it, you're probably abnormal. And then you're proceeding with surgery because you're not checking it. But that sounds like pretty obvious. But that's not what we do. We don't check everybody for vitamin D.
So it's interesting. More than 60%.
Not unless you're not healing or there's a malunion or.
But that's too late.
Generally,
but that's
too late.
But that's too late. So I mean, the vitamin D is so deficient in most people that it seems almost easier to just put everyone on vitamin D supplementation. And, some systems do that. They say, you know what, forget just screening, just give them vitamin D because it may be cheaper. For me, it's important to actually know where they're at so I can change their regimen and then maybe pause on surgery and say, look, you know what, you're not there yet. Why would I operate on you at this point if your vitamin D is so off? I think where we do feel comfortable and we've already kind of achieved this is on the A1C, right? I think all of us, unless it's a trauma, someone comes in with a trauma, if there's an elective surgery and someone's A1C is through the roof,
shouldn't operate on them.
You shouldn't operate on them, right? You say, look, go get this thing taken care of, come back. And so the question you asked me earlier, how long does it take? So all of these things are a little bit different. And this is where, with some of the stuff on nutrition, with supplementation, with dietary changes, It could be as little as 3 weeks. Sometimes it takes 2-3 months.
Yeah, right.
Vitamin D.
A1C definitely 3 months, right?
So
to
A1C
major changes. But
so
you look
A1C,
at fructosamine.
Yes, you remember that.
remember.
Very good. All right,
Yeah,
very good.
Yes.
Yes. So the same with albumin. Albumin is a much longer assessment. The half-life is about a month to 2, and where with pre-albumin, it's only about 48 hours.
What about just giving everybody XR?
So I recommend supplementation.
What if you just say to do the surgery, you got to take some kind of supplementation? That's my point. Some kind of regimented supplementation that fills those gaps. Obviously, I think knowing is good, and especially since we don't know that there's not a lot of realization from the public that they probably have vitamin D deficiencies, and even in California, this could be all across the country, especially during long periods of winter. And then, you get deficient. I was surprised because I was deficient in vitamin D. You don't look like you would ever be deficient. Dark skinned people or just people who are always in the sun, but you go to work at night sometimes or in the morning and it's dark, and then you just never see daylight. Then it's dark. Daylight savings, I think, is a terrible thing. I feel so much better when it's not daylight savings, but also there's more daylight during the day, so you should be out there as much as you can during the day because the vitamin D is so important. But you're deficient is the key, and so you're identifying more deficiencies. So what's the rate of people that you would say that you find in your practice that you pause on and then you have to intervene on those types of labs before you do surgery? Like what rate gets through to surgery the first time you do labs and you say, oh, okay, you look fit, you look healthy, your labs look good, let's go? What percentage of people is that versus it takes time to correct something?
So I would say about 30-40% of patients are good. Now, my population...
so it's still
no, but I tell you,
but
my population also is, I take care of pediatrics, some ACL cases that are 13, 14-year-olds, all the way up to doing a reverse shoulder for a 75, 80-year-old, right?
Sure.
So I looked at my numbers. So, for example, are my numbers with all my patients, all comers, 60% are deficient in vitamin D. 60%, and that's across. And interestingly, because a lot of my elderly patients are taking vitamin D, there are more younger patients who are deficient. And they've shown that in Japan and some of the Chinese studies where because those communities, the elderly are out gardening and the younger population are working, they're seeing a bigger issue with deficiency in the younger population than the older. So this is why I screen a lot of my ACL patients, and there's a lot of good literature. I know it's a shoulder kind of podcast tonight. But
it better be a shoulder podcast. You keep it that way, above the belt here. Okay, shots above the belt only.
But for those of us who do ACLs, there's good literature.
I used to do ACL. They did a few.
Now, Dr. Jazz, even if 30 or 40% of your patients are ready to go, you're still optimizing them with things like prehabilitation and other things in advance too. I mean, they're never completely ready to go, are they? I mean, in many ways, your case starts long before the case ever happens in the OR.
Yeah, I think look, when a patient sits in front of you, they're you have a moment with them where you can optimize them not just for the surgery, but it could be a life-changing opportunity, and I think the more information we can provide them. But it's got to be practical, and it's got to be in a way that they can. We don't have time at this, and that's the other issue, right? To go through all this, so it has to be something that's practical and easy to do. I think optimizing starts with I do prehab. I get even my rotator cuffs. I put them into pre-surgical exercises.
At home, they do it at home, or they go to a therapist.
I use a digital. I use my Health Track, which is an app,
so they can learn on their own home exercise.
The sooner patients are engaged and involved, because we're in California. I'm in LA. Our patients are they're high demand. The expectations are high, and I've learned from my patients to then share that with them to say, look,
a lot of people want to know what's the best route, what's the best way, and I'll tell you, we figured that out. A lot of that stuff.
Well, right? We're working on. To me, I treat my surgeries and my patients like the athlete. This is my whole analogy with the surgical athlete. I tell my patient, look, you're an athlete, and your surgery is the championship game. We're going to get you ready for it. And these are all the different variables.
I feel ready, coach. The way you
Let's
look
go.
at me and tell me that, I feel ready.
Yeah, because, but they want that, right? Your patients
Yeah.
want to feel the confidence
Sure.
in you, right? And also, I have the criteria. If their BMI is way too up,
Right.
I tell them, look, this is we shake hands on it. You get your BMI here, I'm doing your surgery. You get your numbers here, I'll do your surgery.
How many people are kind of either upset about it or look at it negatively?
I have to tell you, it's definitely not what I used to get when it was, oh, you're too overweight or stop smoking. It's a very different conversation because they feel like you're their advocate.
It's like, I thought I was healthy, and then it's like, why is my stuff off? We got to look into that.
But it's all how you present it too.
Some people
right?
say that.
It's all in how you present it to your patients. If they feel like you're their advocate, you want them to heal, right? You want them to have, have a good outcome. So if you present it to them that way, say, hey, look, I want you to do well. I'll do my part in the OR. I'll put in, the best implants and the best biologics, but I need you to do your therapy. I need you to not overdo it, right? And I need you to take care of yourself so we can have a good outcome. Look, you and I can fix it, but getting it to heal really involves a team effort.
Right. Yeah. What do you think the hardest thing about doing shoulder surgery is? Because you've been doing shoulder surgery for a while. And do you find that getting people, like, it's a behavioral kind of adaptation with your patients? Or do you find that what has been the most challenging thing for you as a shoulder surgeon? For me, I can tell you what mine is, but mine has been, technical from the start. It's doing the challenging cases, but then it's looking at the outcomes and seeing, oh, okay, I thought that was good, but I should have done this. That part I didn't understand is going to take time, but you got to do the cases. And as a shoulder specialist or shoulder surgeon, 'cause you do revision arthroplasty, you do knee as well, complex revision, or ACLs and stuff like that. So it's similar, but same thing with rotator cuffs, because then you're doing a reverse, and then you're doing maybe something, if the reverse falls apart, then it's like, hey, what am I going to do now? Because if you do revisions, you got to handle all the stuff. I just did a complex total elbow revision, and it was a case that I had done. And then it's, why did it fall apart? Looking at those things, because then the next one guesses who it's coming to, right? And so you start learning from that, from kind of just by, time on the job.
Oh, absolutely. I mean, we're learning all the time, and I'm still learning it. But I think my biggest challenge with my patients has been matching their expectations with what we can really do, right? I mean, if it's someone comes in and I just had another shoulder arthroplasty guy's in his 40s, bodybuilder, bone on bone, and he wants to go back to powerlifting again, and I'm like, I can get you a pain-free shoulder, but for you to go back and lift at that level, I don't think you're going to be able to have that sustained for a long time. So I think it's that to me has been the biggest challenge, where patients come in, they're like, just fix it, doc. It's not like, hey, change the tire and go in and go out. It's more complex.
I've been seeing some of the durability issues with some of the partial replacements, like the hemiarthroplasties, more so the total shoulder replacements if the glenoid goes out. And there was that big Eclipse study that came out recently that showed
Scary.
50% failure rate.
Yeah.
And I think an issue is if the materials aren't right, or if they're not, then poly never ingrows, and so then it could cause this catastrophic wear pattern, which I revised some of them. So I was seeing some of those problems. So I wasn't putting those in. So I was a lot more careful about that with polyethylene in bone. But I think that, once you're doing your own revisions and other people's revisions, you're seeing how things fail. I still see failure with total shoulders, like anatomic total shoulders. And I look at the durability of the reverse, and it just is this big pathway that you can fix a lot of problems with, so the better you can get a reverse, and I think keep as much cuff, but then, really try to work on getting their muscles recovered and then getting them just overall recovered from surgery. They have a really good outcome and can be very durable.
The reverse is very forgiving.
Yeah.
Anatomic, you got to get it really right.
Well, I've been trying to get a reverse more right too.
Yeah.
Like, looking at some of those issues of, hey, can they do this? No, but they can go way out to the side. But then some people look at that, it doesn't change based on humeral version. So then you got to look at your own results and how you're if you can talk to yourself and say, I know that outcome is what I thought it was going to be. And it's either really good or it's just, I think I could have done that better. So I kept looking at those ones that weren't just perfect, and it was like, hey, maybe they're either too tight, let me try to loosen them, maybe try not so much lateralization, you don't need as much. So I was kind of tinkering with stuff like that. So a reverse is becoming more interesting to me because I'm more about getting the reverse right for each person. And that's why, if you can optimize all the other stuff, the muscle, their surgical recovery, hopefully they have a lot of energy. That's what I've seen with XR. I'm pretty much telling my patients I'm giving them access. Like we talked about, they want to know what's the best pathway. I give them the XR talk and I say, this is something that is important that I think you should take. You're going to get surgery around the time of surgery. So you're screening for labs. I'm not screening for labs like that. But almost everybody who's getting surgery has a significant better outcome with XR. They just feel much happier. They have something that they do. I don't hear complaints about pain, and then I say, did you get the shakes? Are you using them? And the biggest complaint has been just people that are trying them early on and they just have like GI discomfort, or they just complain about the diarrhea, but it's probably just sometimes, it's just osmotic. You have too much water. You're kind of elderly. So I go, you got to go really slow with this stuff. Yeah. But especially around the time of surgery, people are like, I got to do this, I got to do that. They're nervous. So one interesting point about the XR stuff is how people are going to be taking it. Because you're starting some clinical trials at NYU. Mm-hmm. Have those begun yet?
Yeah,
the interventional trials?
Yeah.
So that's why I'm so interested. Because obviously with these clinical trials, you're going to listen to any little possible side effect and major adverse side effects and those minimal adverse side effects. So do you have any provisional data from that?
I mean, we just started collecting them, so I think it's early, and it's a hip fracture study. And we have a knee arthroplasty one coming. We're looking to do a rotator cuff study as well, and an ACL. So these are the ones that are kind of up and coming. There's another one that we're looking to do with orthobiologics, and currently working with Dr. Mazaka at Harvard to look at Gus, and he's
is he at Harvard, or are you doing the study at Harvard?
He's at Harvard, yeah, he's at Harvard now, and
his clinical practice is there.
Yeah, he's shifted there, and So, and we're looking at the impact on mesenchymal stem cells and bursa in particular, and enhancing the bursal cell differentiation and proliferation with using amino acids.
So, what do you know about? I know you know a lot about that stuff. What do you know about Muse cells? Do you know anything about Muse cells?
Yeah, so
have you heard about that, or is it just because I told you today?
No, I'd actually heard about Muse cells.
Well, I was going to talk about Muse cells because of the mesenchymal stem cells and the stuff that Mazaka was working on, because I think that the Muse cells thing is going to be what kind of stuff is going to be targeted for cellular healing, and what kind of stuff is going to actually have an effect. Because you can take XR, you can feel good, your muscles are strong, but if you have a tear, a full thickness tear, even if you just say, hey, take XR, it's going to feel really good. And your muscles will feel better, but then you stop taking XR, you're not feeling as good, and you still have a tear. It's not going to heal your tear, right? No. And so we're talking about certain ways that we can modulate your body's response to things.
Yeah. So, for me to kind of take a step back, I'll tell you, this is why, for me, this is a complex issue, but we got to break it down into like piecemeal things so we can kind of have an organized, kind of thought process with it, right? So for me, this metabolic assessment, right? You say, so yes, I do recommend nutritional optimization using XR for all my patients.
Intervention.
That intervention, right? But that's just one aspect of it, right? So for example, someone can come in and be supplemented and have the nutrition, but if their hormones are off, if their A1C is off, if their vitamin E is totally off, then you've also neglected that. So I think, XR is just hitting one category, and, that's where I kind of, started. But now that I'm looking at all this stuff, I'm realizing that it's a very important piece, and in some studies they'll say this may be the most important of all the different variables, whether you're looking at obesity and diabetes and nutritional status. Nutritional status kind of stands out to be the most prognostic as far as complications go.
It's emerging data that hasn't really been fully looked at, especially by orthopedic surgeons.
Especially in orthopedics,
so
we're finally catching up.
Data.
We're finally catching up, but I think the overall problem is healing, and nutrition is one key aspect of it. This is where the other variables to enhance the healing signals come in, and this is why for me, I'm very interested, and I implement a lot of biologics, right? And so, I have this approach where I call it the biofertilization protocol.
Oh, hey, you can't jump around like that. Okay, we got to stick on it. No, I want to talk about that.
Yeah, but that's
we'll talk about the cool stuff with like how we're intervening on things.
Yeah.
But before we do that, if you don't mind, I do want to talk about. So you talked about the screening protocols at the ICM meeting.
Yes.
And then there was consensus on intervention, or there wasn't? I didn't quite get that part.
Yeah,
and what was the intervention that you guys found?
So everyone agreed that intervention helps decrease issues and complications. Intervention was a protein-based supplementation. So it was great because it really helped narrow kind of what we're talking about, and the protein-based supplementation, when you go one step deeper, is really, what are we after when we talk about protein?
Mm-hmm.
There are specific amino acids within protein that help with the healing process.
Mm-hmm.
So that's where I'm excited because I feel like we're already ahead of that.
So did they look at just adequate protein intake, total protein intake for
The studies that looked at the efficacy of supplementation?
They gave protein shakes, or they gave amino acids?
So both. So
Okay.
they looked at this was
Because they're looking at all the studies on those topics.
the last 3 years they kind of pulled all the different studies.
Got it, like a big meta-analysis, and then
it's
made
Exactly.
consensus.
That's exactly what it
Statements.
was,
Mhm.
right? And so it was based on all the data that was presented. And so they pulled all the different supplementations that were done. And what was consistent is the role of a protein-based supplementation, which means either protein shakes or amino acids, which help decrease the complications.
Was there a certain minimum number that they found, or anything that you saw as like a
No.
minimum threshold?
It
that
was
they could
that's
say,
that
"You should
this
take
is
this"?
even with the consensus on the screening, they were hard pressed to say exactly what. The comment that was made was at minimum albumin, because there's different ways, and we still don't have the best answer. Albumin is a proxy at best, right? We don't. It's really hard. It's not like hematocrit where you know exactly what the number is. This is like I said, it's a nutritional spectrum, and albumin is an inflammatory response protein. So it's good because it's been over and over shown to be correlated. But to really dial it in, I think we're getting much more. We got to get much more specific, and this is where the research is looking at different ways of assessing someone's kind of status. And we can get into this a little more, but looking at someone's maybe body composition.
Which specific markers?
Body composition, for example.
Mm-hmm. Like what about them is going to tell you they're malnourished
or nutritional? Yeah, so
not nutritionally optimized.
So albumin, pre-albumin.
Mm-hmm.
You could look at that. You could look at also lymphocytes. But
total lymphocyte count.
Total lymphocyte count.
Mm-hmm.
Yeah. But the other one that really is coming up again is muscle and sarcopenia and how much muscle you have. Traditionally we look at patients' body weight, BMI, but that doesn't tell you about body composition. So I think where the next level is body composition. So looking at sarcopenia, and that tells you about how much muscle that you have, and your body composition is actually very closely related to your outcomes and is also overlaps with nutritional status. So I think this is where I think it's not going to be one number, but I think it's going to be like this collective report card, or whatever you want to call it,
Mm-hmm.
where we're going to screen this, just like the Rohe score, right?
Mm-hmm.
You take away kind of the top five or six variables and you put them together, you get a score.
Mm-hmm.
And I think this is where we're going with this.
So did they make any other conclusions at the meeting, or were those the main conclusions?
I mean, there was over 100 questions.
Like in sub questions, like smaller.
There were 100 questions.
Because usually, I think the reason why I asked that, I mean, at the last meeting, I think there weren't any major consensus on what constitutes a shoulder infection. I know that about.
I think
shoulder.
this is my first meeting, so
and
I
there
have
was
to say,
some major gaps in our knowledge and literature.
Yeah.
And so now that it's been 5 years, there's been a lot of updates.
Yeah, I mean, the shoulder session I was really excited to be a part of that.
Yeah. So your involvement was through shoulder, or was it for
it was
overall?
for the whole thing, but I also sat with the shoulder, and Serena,
Serena Namdari.
Yeah, he's great, and he did a great job with the shoulder subcommittee, and that was great.
Did he chair the shoulder?
Yeah, he was great.
I thought so.
Yeah,
because he was a delegate last year. I know. I don't remember where it was last year. Was it in Philly?
I think it was Philly.
Yeah, it's Philly.
Philadelphia.
And then this year was Turkey. So you guys spent, how many days was the meeting that you spent going
I think
in?
4 days.
It was 4 days
4
for the
days.
meeting. It took them 100 questions over 4 days, and they stayed late some of the days too, just to be able to get through all the questions.
Mm-hmm. So it sounds like an exciting meeting.
I thought it was incredibly engaging from a non-physician perspective. I've been to a lot of the orthopedic conferences where everybody has a meeting. You share your case. People are finishing them, in the speaker ready room in the morning. But this was so well organized, knowing that this panel took 5 years to put together their presentation.
Yeah, major international speakers.
And everybody was so engaged with their transponder. It was really on the edge of your seat. Nobody's falling asleep at this meeting because they know that they're writing law together for the whole world to follow. This. It was really exciting.
It was a very unique experience to see everyone super engaged. It was their work that they've been really like looking at for the last few years. They were all the experts in their subspecialties, and so it was very well organized.
Was there any specific sections that you did on XR or on interventions such as protocols with supplements similar to XR? Were there any talks like that?
No, I mean this was really just kind of the consensus on where we stand even on screening. I mean, the stuff that you and I are talking about are way ahead. I mean, we just got to get people to even...
Yeah, smaller scale in terms of like local. Does this have any effect on a smaller scale with a specific question in mind? Because the musculoskeletal infection you got to have so many infections that you can even look at what are the results, how interventions can have any kind of an effect. So large scale studies need to be done.
Well, I think that's the next step, right? So now that we have this consensus that, okay, we should be screening.
That's what I was going to ask next. Where are we at with the meeting and kind of what's next for infection treatment?
Yeah, so I think this is now, we get back and we look at, okay, what do we learn from this? Where are we at? And then what are the next studies that we want to do to then answer some of these next level questions that you're asking?
Mm-hmm. Yeah, so what studies?
So I think this is going to be multi-center studies looking at, how much the impact of screening, right, and intervention, and seeing. So we know that we know that patients that are not optimized have complications. What we don't know is how much the role of intervention will decrease the infection.
And that seems like such an easy study to do, because you can intervene on something that seems to be pretty much helping, and then all you do is look at, do you have excellent results or just slightly less than excellent results? So you're not really having much risk of harm in something like that. So do we have less problems, less infections, less complications?
So in the hip and knee, it's done. In the hip and knee, that's been shown. In the hip and knee, it's been shown that intervention does decrease complications, improve functional recovery, decrease, improvement outcomes, less muscle loss, particularly in knee arthroplasty. That has been shown. Hip fractures as well as hip arthroplasty and trauma. But shoulder arthroplasty, where we're at right now, is just showing there's a direct correlation with poor nutrition and rotator cuff re-tears and complications with shoulder arthroplasty, revisions, infections, and readmissions.
That's major.
And readmissions.
Yeah, that's major. Yeah. Those are all things we just expect to avoid. We never expect problems like that. You want to optimize those patients because they're going through a lot just to recover from a shoulder surgery.
But just because of the sheer number of the cases that are done, hip and knee always goes first.
Well,
right?
They have a lot more numbers, bigger numbers,
way more bigger,
more problems. Or no, I would say more people with those types of problems.
That's right. And so shoulder arthroplasty is now next in line. But I think you see the numbers just exploding.
Yeah. So in terms of XR and using that as a surgical supplement, I mean, really my first show with you was so exciting for me because I was learning all this basic science behind it that I was just seeing, this is something that makes sense to me. Other people are using, let's see how it works. And then talking to you about the basic science about really how you founded, the company and really formulated it. That made sense and that was cool. And then I've really been intervening quite a bit in my own clinical practice, meaning talking to my patients is saying, hey, at least introducing them, saying, hey, you should take this.
So how's the conversation gone for you?
Oh, it's pretty easy. It's because it's gone. If I don't bring it up and talk about it, then they may walk out the door and then they're not really aware of it, even if the sign's up. But if I say that you should look at this and I would recommend it for your surgery, because a lot of times it's those meetings, which is basically my pre-op, but I will pre-op people at that meeting where I indicate surgery. So if we're going to do that, you would probably pause, get labs, we check, we follow up, so there's ways that you can do these pre-op meetings and then you check everything. And so we're getting a lot of information across. People are thinking about things, they're getting their labs done, and they're doing a lot kind of in the background. So that meeting where we decide on surgery, that's when it has the most effect.
That's right.
And then they understand the things that they're going to need for surgery. It's like going on a backpacking trip. You got to make sure in your backpack you got your switch, your little knife, right? You got your stuff to start a fire. You need your stuff with you. That's going to help you get through the night. You need your tent. So it's an ice machine, which is a no ice machine for me. It's one of those coolant machines, and it just ices it. Like I have the cold plunge right in the podcast studio, so we can do that later if you want. I showed you that, Gray.
Yeah.
Showed her. Was it cold?
Yeah.
It's pretty cold, right?
It's great.
So ice, right? Ice is your friend for recovery. So if you can ice your shoulder, you should definitely do that. That's one of those things. And I'm going to give you this unit that you can use. It's just going to be your friend for the next couple weeks. And then you get the XR nutrition, and that's really important too, because you should take that a week before and then 2 weeks after. And that's just like the recipe for the stuff you're going to need to take with you. So then that's been working really well. And that's why the talk goes really easy, because people want to know, what can I do? And then we get to the pain medicine and all that stuff. It's like, don't worry about that stuff. But the oxycodone and the tramadol, all that stuff is last, right? You don't want to rely on that stuff. You want to do all the other stuff first, the natural stuff. And the supplements if you can, and the physical things that help you when you do have pain. And then that's like 90% of recovery after surgery. And then you take the medicine if you need to. So that part of it kind of, dialed up, and it's kind of just about getting the people the information. The next part about XR that I thought was cool, and that was the second reason why I wanted you back on my show, was because XR seems to be a real significant performance supplement that you can take if you work out a lot.
Yeah.
And when you came over and I asked you, I was like, do you take XR? You say, yeah, I take it every day because I work out every day. So I need recovery every day. And I do jujitsu. I learned Gray does jujitsu too. She has a background with that. I want to hear about your stories with the Gracies too.
Yeah.
That sounds cool, if you want to talk about it. But it's, using that as a significant, just a supplement when you're having muscle soreness, the DOMS, right?
Yeah.
DOM, delayed muscle soreness. You take the supplemental amino acids, and you can just really use it. And it's really safe to take. It's totally certified and approved by the major sporting organizations, right? You guys can talk more about that. But that's the next part about it, is just kind of regular use for upkeep, for like human performance upkeep. That's how I kind of look at XR. I always have it stocked in my cabinet.
I mean, I'll tell you.
And my mom takes it. She loves it.
What's interesting is that a lot of the literature that has been borne out on the supplementation side is not in orthopedic surgery. One of the reasons is we've been in the operating room. We're worried about implants, and that's been kind of where we're focused. But the metabolic side of performance, the athletes have got a lot of attention on this, right? And if you want to do a study, it's much easier to do a study in that setting than it is in orthopedic surgical. Getting IRBs, double-blind, studies are really hard to do. So performance for athletes has always been an issue, and so optimizing performance has looked at all the different variables. When I looked at this, when our orthopedic patients are coming out of the operating room, they are going exactly through the same deficit, and they're getting metabolically hit with the same issues. So in order to support their recovery, it only made sense to me to also look into that aspect of recovery. And so we look at muscle healing and muscle recovery, what these athletes are looking to do. This is why there's so much overlap. And so a lot of the studies that have been already done, looking at, for example, delayed onset muscle soreness, or DOMS. So DOMS is kind of like, how sore do you feel after a workout?
After squats,
right? After squats, right? But that's
lasts for like 3 days.
Yeah, so but that's a subjective thing, right? That's you can ask someone how they feel.
Yeah, but if I work out regularly, I usually don't get it. It's only if I haven't worked out for a couple weeks, and then I'm going to do squats or something. It's like, kills me.
Because you've really overstressed the body in a new way.
Yeah.
Now you can actually check that objectively.
Well, I try to go light when I go back, just to not to have that effect. Because I feel like if I lift the same amount of weight or try or close to that, I get really sore.
You can actually objectify that. So there's an objective way of checking.
I don't mind
DOMS.
Objectifying things. Let's do it.
So you can do a blood test. So when you have a heart attack, for example, you check troponin, right?
Yeah.
Troponin tells you how much cardiac tissue damage you had, and that spills into your blood, and you can gauge that. That's why someone says, "Hey, I had a small heart attack, I had a massive heart attack," right? What does that really mean? They're just checking the troponin levels, right?
How much of the muscle was damaged?
And you're looking for the troponin to come down. That's where you're recovered. Same thing happens with really intense exercise. And so a lot of the studies have been done on some of the elite athletes, particularly in soccer players who are doing a lot of eccentric running and running back and forth. You can check their creatine kinase, which is tissue breakdown from exercise. And you can also gauge, which correlates with DOMS, right? So one is objective, the other is subjective. And so you can check how much muscle tissue damage you've had by checking someone's creatine kinase. And that is something that a lot of the supplementation that's in XR was based off of that. So when I looked at it, I said, you can actually mitigate a lot of the catabolic issues that you see and enhance the muscle protein synthesis that happens during these exercise bouts.
Wow.
Yeah.
So what about the intense muscle exercise breaks down the muscle like that? That it can even form rhabdomyolysis
That's
in the
right.
kidneys.
Rhabdo.
But those are the breakdown products from the muscle itself that collect. But what was it that's where you kind of saw the potential area for intervention.
Yeah,
right.
because,
To prevent that
that's right.
problem.
You do shoulder arthroplasty.
Yeah.
We cut. We damage tissue, even though we try to be minimally invasive. We still damaging tissue, right? And so a lot of the patient's recovery is based on the ability to shift the balance. And so what's happening in all our bodies all the time is this flux, this balance between breakdown and making. So anabolic, catabolic, right? And we see it in bones, osteoblast, osteoclast. With muscle tissue, no different. While we're sitting here, there's muscle breakdown and you're making muscle. So you want to
Doesn't
shift.
feel like it.
Well,
yeah, but it's true. It's always that balance, right?
That's right.
You don't think about it that way, but you're either fasting or you're fed state.
That's right.
It's one or
That's
the
right.
other.
And it actually goes through a cycle.
Yeah.
And so that cycle, and this is why you look at
or your body temperature goes up and down. It's not just 98.6 all the time. It's a little hotter, a little colder. Depends on the day and the time of day too.
So this protein breakdown and synthesis is based on exercise. That's one of the great ways to stimulate protein synthesis is the stimulus of exercise. But inherently, when you exercise, you also have some breakdown. You actually cause muscle damage. But the net result after exercise, because you triggered the muscle to then respond to that, you send an anabolic signal. And if you actually eat the right foods, i.e. protein or the right amino acids, that becomes more anabolic. That's how you put on the muscle. But so absolutely every single time you work out, there's some muscle damage that happens inherently. But the overall effect, if you're resting and you're eating, then you put on that muscle. And this is where you can come in with nutritional supplementation, specifically, the stuff that has been shown to be anti-catabolic and pro-anabolic to then kind of shift that. So these, if you look at some of these clinical studies that have been done on athletes, you can actually slow down the delayed onset of the tissue. So that's called EIDM, exercise-induced muscle damage, EIDM, and that is the objective way of looking at muscle damage through creatine kinase laboratory values. So by providing the supplementation, you actually decrease EIDM and DOMS. And this is where a lot of these athletes are able to shave off some time and get back to sport earlier, have less pain, and less injury. This is what we're looking to do. So with a lot of these athletes, when they're really dialed in, some of these professional soccer players, they will look at their EIDM and how much muscle tissue damage they've had. And they say, look, if you're too high, then maybe we shouldn't put you back.
Right. You want to know where that threshold is.
That's right.
So you can push that line, but not go over it.
That's right.
Because you cause too much damage.
And if you can supplement.
Yeah, you can extend the line. You can make the line longer, maybe, right? So you have a bigger tank.
By preventing breakdown. And if you look at performance for athletes, if you have 8 months to train for something.
Yeah, of course, by preventing breakdown.
And as much as you can. And so,
Yeah.
and so if you look at, for example, performance. So,
But what my point is that line of where you enter into that breakdown, there's some kind of threshold there. Because I know when I train, I get stronger. My endurance lasts if I'm training harder regularly. And then and then I do 6 sessions. I do 7 sessions. or 7 rounds. So I'm pushing my body. And then the next time I do 6 rounds, I can go 7. It's kind of easy. So I can feel that kind of that change.
assuming you're fully recovered.
Right.
And
right.
so,
but if you can find that line,
Yeah.
it's kind of like doing reps in the gym. You find that line where you're just about to give, but you just got to push a little bit more. That's that kind of stimulus that you're talking about, right?
And so, and there's the stimulus comes from exercise. And similarly, just like how you have to go to the gym and you have to lift a certain amount of weight to get a result, to hit that trigger, right? For your body to say, okay, I'm under a lot of stress, enough stress to actually cause this signal to come on. The same happens with nutrition. You have to eat or get the same loading dose of amino acids to be high enough to be able to trigger that muscle protein synthesis. This is where you can kind of, biohack. And if you understand that, you can have more of a synergistic impact. I mean, number one is exercise, but then you can supplement or have the right nutrition to then really get the most out of your routine.
Mm-hmm. And so then what would you say is the most important thing for nutrition after exercise if you're trying to build muscle? Would you say it's amino acids, or it's getting the right protein amount, or is it both, like getting the correct levels of those amino acids if you're trying to build muscle? Because you got to get the stimulus, but then how do you build muscle too? So we're not talking about surgery, but talking about performance optimization. Is that something that you can biohack?
So that's a really complex question, but
Yeah.
I can give you like the...
They perform similarly, right? Like if you can get amino acids in the right combinations, kind of like XR. I mean, that's
a lot
the
of
idea.
what we
Is
do
I
with
take
XR.
Yeah.
right. I take XR after I work out. That's kind of my question.
Yeah,
how is that different than a
Real,
protein shake?
It's really targeted nutritional
I feel
supplementation.
like it works a little more.
I think the reality is
It goes to where it needs.
if you're getting adequate amount of dietary protein,
Sure, that's what
intake,
I'm saying. Yeah,
right?
adequate.
So
for your weight.
I mean, first of all, I think most of your dietary intake should come from whole foods.
Mm-hmm.
So that's number one.
Mm-hmm.
Okay, and then I think the biggest trigger you can pull after that is actually doing the exercise. Okay, now if you want to make sure you're not missing any gaps,
Mm-hmm.
you're older, and that's something that happens as you get anabolic resistance. And that's just a reality. As we get older, we have this called anabolic resistance, which means for the same 20 grams of protein that I would eat, someone or a 20-year-old would eat, someone who's in their 50s, they would have to eat more because your body has a blunted response to the same exercise and to the same protein intake. So in those situations where you're trying to make sure you fill the gaps, this is where supplementation is really effective. So you make sure you're covering your bases.
Mm-hmm.
So as far as the timing goes, I think it makes the most amount of sense to take your supplementation right after you exercise.
Mm-hmm.
This is a very complex question that a lot of people have done a lot of work on this. If you listen to guys like Peter Attia and some of the guys who've been really working on this for a long time, Peter Van Luke, he basically recently showed that, if you eat a lot of protein, your body will consume it as long as you're exercising. So it's more of a lifestyle and, what you're doing over the week, as opposed to just that one meal.
Yeah, Huberman was talking about that too.
Yep.
I think he was talking about the fact that if you're eating the right thing ahead of time and then you go work out, it's digesting over time.
That's right, because if your
body's going to get it
that's
as
right.
long as it's there.
That's right. So if you're eating and you had that anabolic signal to put on muscle protein synthesis, that'll last for maybe a few hours, right? The problem comes in for us as surgeons when we tell patients to fast.
Right.
Exactly. We tell patients to fast, don't eat anything.
Yeah.
And then they go home, they're not hungry, they're vomiting, they're nauseous, right? They don't feel great, they don't have an appetite. That deficiency in a patient who's not just had a hard workout, they just had surgery, right? Mm-hmm. So this discrepancy between what they really need, this mismatch continues to grow. Mm-hmm. So I think that's where we can really come in, right? And this is where we can have a big impact on our surgical patients who they've had the massive workout, if you want to call it. Their appetite's off. They need these extra essential amino acids for tissue healing beyond just putting on muscle. this is why for me XR was not just for muscle. Yeah, we took all the information from the athletic side, but it was also looking at collagen synthesis, rotator cuff, bone healing. We're talking about enthesis of the rotator cuff tear. These are all predicated on having the right building blocks at the right dose. So this is where we pulled all this stuff together. And yeah, absolutely the performance side of it was it's kind of a plus, but an important piece of the recovery aspect to get our patients. I mean, what percentage of your patients are now outpatient?
Almost everybody.
We want to get them out of the hospital, get them home as soon as possible, right? They got to have the resilience and the strength to be able to do that.
Right.
This is where all this comes together.
Yeah, that's that first follow-up. And that's where I really feel, did they have what they need, and did they do what they need those first couple of weeks following surgery, week and a half, whatever.
Yeah, I think we were talking about this earlier is like,
and they just feel either pretty happy and they're set off on the right path, or they're just like, man, what did I just go through? It makes it's kind of a big difference in terms of like their mental status.
I think Gray was talking about this before about, XR is for surgical recovery. Why are all these other people taking it?
Yeah. Who takes XR?
Yeah.
Gray? Who else takes XR?
We all take XR. I would say 90% of the surgeons that recommend it take it for themselves.
Can you just come a little closer?
Oh, yeah.
Yeah. That would be a good thing.
I would say, the majority of the surgeons actually that recommend XR from the beginning took it for themselves for their own injury or surgery and had such a great experience that they started recommending it to their patients and using it ongoing. I think in orthopedics, I find a lot of the surgeons come from a sports background themselves. They're running Ironman. They're at the gym. They have a sport they're into already, and anybody over 40 is wants to keep our muscle mass on as much as we can. And this is where you had mentioned like what's the difference? Why not just protein powder and why XR? When we're eating a healthy diet already, a lot of us are eating high protein, we're optimized, maybe it's low carb, but we would need that extra, supplementation to really get the recovery that we want. This is where targeted amino acids instead of protein powder really comes in because it's only 70 calories, where a scoop of protein powder is maybe 250 calories. So you're not trying to bump up your caloric and fat intake in your diet. You're trying to get the nutrients that you need to recover, repair, and stay strong.
Yeah, and it's hard to know. Even when you're having that consistent diet, you're doing all the right things, you're taking your vitamins, but then you're pushing it really hard because you're an athlete. Then how do you know? One day I pushed it just so hard, and the other day was like a little lighter. But then you got to make sure that you're always covered. Otherwise, you could be at a deficient state, a relatively deficient state, just because you've been, pushing the training harder because maybe you have a competition coming up.
And I'll tell you the other interesting thing is that. So protein is great. It's important for what we're talking about, but there are also other important aspects of XR, like that's not in creatine, that's not in protein. So creatine, for example.
Yeah.
So creatine, as you know, has been used again for a long time for athletic performance. But now we're seeing it's being, how it can be helpful for orthopedic surgical recovery. There's also cognitive aspects of
I feel
creatine.
Cognitive benefits with creatine.
So that's the other aspect. There's creatine in XR.
Like a little sharper, just like a little, memory's a little tighter.
It's interesting because...
Take it before podcast.
Yeah. Because, the creatine, it was always thought about, we always thought about creatine as something for muscle performance, right?
Yeah.
But the way creatine works is I don't want to get too deep into the science of it, but essentially it's on a cell.
I want you to. It's like a cell, it's for ATP and it gives you more.
That's right. It's ATP, right? It's ATP, it's phosphate, right? So it's cellular energy, right? Yeah. So cellular energy on a muscle side means if you're trying to, do a max weight lift or you're trying to sprint, that's not coming from fat. That's not even coming from carbs. That's coming from ATP. So you need to have that phosphate available so you can have that ability to perform at that level, right?
Or if you fall and you got to catch yourself real quick, those are your fast twitch muscle fibers.
So what's interesting is, yes, the muscle, but guess what turns on the muscle? The nerves, right? And so that cellular component is just as important on the brain side. And in order to be able to have that reflex or have that memory, and a lot of studies have been done on creatine on the mental aspect of it, has been done on healthcare providers who work overnight because you get stressed, you're fatigued. that mental fatigue when you're thinking, or you're extra stress in the body, that depletes the creatine. As we get older, creatine also gets depleted. So we know where we store creatine? In our muscle and in our brain, right? And so by providing creatine supplementation, that cellular reservoir gets increased not only in the muscle for muscular performance, but also for cellular cognitive performance. And this is where you see a lot of the recent studies that have been done looking at memory, cognition, and some of these issues that we never even thought about.
Do you know the mechanism for that? Like, what is it, because it's stored in the brain? It's
so
able to fire up more
when you're
energy?
having it when you have that phosphate is basically cash for our cells.
Cache energy.
It's cash energy.
Yeah.
It's like boom, it's right there.
Yeah.
So in order to be able to provide that
adenine triphosphate.
adenosine triphosphate.
Adenosine.
So it takes adenosine diphosphate, ADP to ATP. So that conversion from a D to T
Builds up the energy store.
that's it. So so it provides that's a creatine monohydrate. It pulls that phosphate, so it's available. It's readily available. So it's like
For the muscle to fire and have that energy.
forget muscle only. It's any cells.
Oh, for the brain, too.
cellular. It's cellular.
So how does it do
that's
that
mechanism.
in the nerve? Like, do you know? So it gives it's just the synaptic firing is all just fired up. There's more
that's
energy
what I'm
for
saying.
the mitochondria.
That's right. The mitochondrial efficiency, all of that is predicated on having phosphate available. So that's why it's interesting to see a lot of the cognitive aspects of it is now being kind of talked about more and more.
Yeah,
You
and
know.
women too. I was been hearing more about that in terms of women taking creatine because it's definitely
I got my mom
guys
finally taking
know
creatine.
about creatine, but women that have it's not
Yeah.
as far as I know
Yeah.
hasn't been well talked
Yeah.
about.
So creatine, you're not going to get that,
They
especially.
worry it'll be what you get too buff or big,
Yeah,
but
women
it's-
were worried they were going to get too buff.
It doesn't
but
happen.
I
Yeah.
think with so much cognitive benfet, being marketed
you can build
now,
muscle just
people are
fine.
really
Helps you.
seeking the benefit even more than ever.
I would argue that
You still got to lift the weights and eat the right food.
Yeah,
and all
of
that
course.
stuff.
You got to do all that stuff. But so creatine comes generally in meats. So if your diet, so if you have it,
Right.
so if your diet is plant based, which has a lot of benefits, but one of the issues is that you're going to be deficient in creatine, and so
Energy could be low.
so that's why I think this is really important for my patients who are plant based. I make sure that they're aware that this is something that could also help them. This is why we made XR, vegan friendly, right? So that's these are the things you're not going to get in protein, right? So you would have to take multiple supplements, and that's what initially how this called started. I had multiple supplements. The other one is HMB. HMB is something you're not going to get in protein. HMB is a metabolite of a key amino acid called leucine, but HMB has anti-catabolic effects. So HMB is very helpful in preserving muscle when you're at bed rest or you're in trauma settings, and so you're not going to get that in protein. So that's what we put into XR. This is why it's very targeted specifically for what we're looking to do. And most of our patients that come out of surgery, they're not running around, right? They're recovering, and it's in those first 2 weeks is when you lose the most amount of muscle. This is when you want to bring in that supplementation. So yeah, I take it personally every day just because I'm into it. But for my patients, that's critical, right? The first 2 weeks.
So, you can have a good diet and some people do it, but it's hard to do studies on a big population
Very
of
hard.
people just on diet. It's almost never going to happen
Yeah.
unless you just have some kind of place where you can just enforce that, on
That's
like
why
diets on people, but people eat what they want.
Well, that's why
So
a
it's
lot
hard
of the
to
studies
study
are on
that.
rats.
Yeah, on the rats, right?
It's hard to do.
Right, because you can control their diet at
Yes.
least. But with something that's a product that's something like XR that you can formulate, we were talking about, in surgical intervention, some of the studies that you guys are doing. Do you think that something like that, a targeted intervention, could really prevent injuries in at-risk people? Somebody like athletes, say, for example, ACL injuries in female soccer athletes. We know that ACL intervention had a big effect on decreasing those, but it's not zero. They still have a lot of
By prevent,
ACL
do you mean
injuries.
taking it ongoing or regularly
Exactly.
to avoid these in the first place?
Yeah, what do you think about that?
Maybe.
Because that was kind of my next thought about where does XR go from here in terms of how we can help the general population with targeted intervention on their nutrition.
So I'll tell you
some of the corporations aren't interested in that at all. But I'm interested in helping.
Well, I'll tell you where we do have a lot of interest on a global.
Because maybe you can just optimize people. Maybe you just say, "Hey, I'm taking this thing.
There's certain
I'm optimized.
groups of people that are really into it.
Yeah, and I'm avoiding injuries because I'm working out more. I got more energy.
So
maybe it has a significant effect on people.
So I'll tell you what is
that's why I take a lot of XR.
Even people taking GLP-1 or things like that is a lot of people are benefiting from keeping the muscle while losing the fat.
Keeping the muscle, exactly. Whatever you can do to keep the muscle, because then overall you have less risk of injury and you're healthier.
So if there was,
it's kind of extrapolating a little bit.
But I'll tell you one thing that I think is really important.
Because diet's hard. Sorry.
No, I think to piggyback on your point about how you can prevent problems.
Yeah, maybe. That's an idea that I have.
Then I'll tell you your idea, and I'm looking at it from a kind of a global issue, which is sarcopenia. Okay, so sarcopenia is something that I think we can have a great impact on. Okay, so what is sarcopenia? Sarcopenia is the natural loss of muscle as we age. I think everyone knows about osteoporosis, right? Bone loss as we get older. And we know all the issues that happen with bone loss, hip fractures, and all the problems that we see. But sarcopenia, which is this, we think it's just, it just has to do with age. And as we age, we lose muscle. That's true. But really, that's activity and lifestyle dependent. Mm-hmm. And what I mean by lifestyle is, do you resistance train? Do you exercise? And then are you eating enough protein to maintain that? Because those are the two signals that will turn on the muscle, right, to prevent that muscle breakdown. So this is where supplementation, particularly as we get older, patients are not eating like bodybuilders high protein every 2 to 3 hours, right? This is why these guys are always in an anabolic state. They're working out hard, they're crushing it at the gym, right? And then the other 22 hours, sometimes they'll wake up in the middle of the night to eat. They're getting their protein every 3-4 hours to keep that anabolic signal going. You can't get people to eat like that all the time. It's not practical.
Especially not around surgery.
Mm-hmm.
This is where supplementation comes in, right? This is where it really makes a lot of sense. And if it's done as a lifestyle modification, where you say, look, I'm going to exercise. Again, I'm always going to lead with exercise, eat whole foods, and then use supplementation for supplementation. Fill those gaps. This is how you're going to see someone. And we all have, we will put on our muscle and we peak in our 30s, and then about 8% every decade, you'll drop. But that drop doesn't have to be that way, right? Guess how we drop most of the time? We drop by musculoskeletal injuries. We have an ankle fracture. We have a rotator cuff tear.
Yeah,
we have a hip
you down
fracture.
A notch.
And then it goes boom, boom. And guess who's there to provide some kind of intervention or show them that they can do it differently? That's us. So the role of the orthopedic surgeon is really important in changing the trajectory of where our patients are going to be. And there was a recent total knee arthroplasty study that showed patients that were supplemented for that 3-week program, they had less muscle loss in the first 6 weeks after surgery. And they had improved functional recovery at 3 months. Great. The follow-up study 2 years later looked at those same patients. Those patients who were supplemented had better strength and more muscle 2 years out, which means that the hit of surgery is so significant, and some of these patients can't recover the hit that they take. They never come back out of that hole. And so by preventing that hit early on, we can have a meaningful impact even 2 years down the line. Mm-hmm. So I think, yes, to answer your question, beyond just ACLs, as a global issue, this muscle loss as we get older, we fall, we trip, these injuries, they're much more impactful than just what's happening at this one moment. I think this is a kind of a lifestyle and supplementation where you can kind of do it more on a routine basis.
Kind of something that should be taught in physical education, PE class. How do you build muscle? It's something that should be important. right? It should be kind of stress. Like you guys, should lift moderate amounts of weights. Not like kids lifting weights, but my kids do lift weights. I teach them.
Well, because they're your kids.
Well, of course they're jacked. They look great, and they're little baseball players.
That's awesome.
They're hopefully both going to be in the MLB one day, but one of them for sure. But they got to train, and you watch them and they got to do their thing. But there's technique involved in what the kids are doing. But with regards to where we can optimize people, can we teach them good habits? The kids, you got to teach them good technique, good form, so they don't run into those mechanical problems like baseball pitchers do, right? Because we know that Tommy John surgery is not to make your elbow a better pitcher's elbow. It's when you have deficient elbow, we got to tighten it back up just so you can get back to hopefully where you were, but not everybody gets that way. But it's because of that end strain result of those high forces across the elbow that you're not connecting the kinetic chain with, because you're just some kind of form or technique is off.
It's not an elbow. It's not an
elbow problem. Exactly.
It's a mechanics of how you throw a problem.
Exactly, and maybe a nutritional problem too. So that's why intervening in athletes, they're stressing their body. But that's a different question than intervening on the general population or somebody who might be at risk.
I think there's so many ways this can work for the general population. For myself, I see a lot of people that have done intermittent fasting, and the more and more we learn about muscle protein synthesis activation and the value of amino acids, moving away from, fasting and learning that supplementation, is almost better living through modern chemistry. We've learned how to dial it in to where, we're not guessing anymore. We know exactly what we need. And it's almost like space food. Like we have exactly the nutrients we need to give our body what we need to survive, to heal, to recover. Mm-hmm. And the more we can be educated on that, it's great to know I drank the shake, my body has what it needs for today. Even if I didn't eat a huge steak or a huge salad, I'm getting it exactly what I need in this moment. And dialing in the science there and educating people on that, I think makes a huge impact. Once people know and they're educated, they're excited to do something about it.
I've definitely changed my fasting protocol.
Do you think that it's something that that people can learn on their own, or do you think it's something that like how hard is that for people to do? Because I feel like some people just look at it as just an impossible task.
What, fasting?
I think protein has really...
just understanding their dietary intake.
Protein has made a huge, I think, waves in marketing, where I see like articles on protein in the New York Magazine now, and almost every podcast and health influencer saying something about protein. Here's my protein powder. Tom Brady has a protein powder now. And I think it's just a matter of which protein powder do you take.
Protein's all over the place. Yeah.
And so now I think people have realized, okay, I have protein powder. Probably everyone has one at home. Even my mom does. Yeah. But then are you doing whey or casein or rice or pea? And then,
doesn't go that far.
Then which protein powder? And then... So I think that was almost the first wave. Is like, okay, we all know we need protein. And now what is it about protein that we're all trying to get after? Mm-hmm. And I think amino acids are sort of that next level of education where people are really starting to understand what all this protein craze is really about, what we really need. And I feel like we're at the forefront of that.
Proteins are complex amino acid structures. That's what they are. They're amino acid structured, and then they form a protein. So they're just more complex amino acids. So if you're getting a lot of protein, but you're not getting all the amino acids, you might be deficient in your, not total protein, but in the right protein for maybe muscle building.
Exactly.
So these are just basic.
Not all protein is created equal. Exactly. Is the next, I think, conversation people are really starting to understand.
Like markers or enzymes or things like that do different things in your body. So you can't expect you just to get everything. It's like watering my trees, right? So if you have plants outside and they're going to produce some kind of interesting fruit, you can't just expect it to get it out of soil that's just barren. It has to have nutrients in the soil. That's where they get all that interesting chemical. Yeah, it's got to have some fertilizer, something in it, that carbon, and then they do their magic. But it needs what it needs to do that magic. Otherwise, it'll never do it. You can't just give a plant water and sunshine. It has to have nutrients of some sort, especially the interesting ones with fruit and stuff like that. But I think that I was going to ask you a question about the optimization pathways and what you just brought up about XR. What do you think about instituting that with the new flavors that you came out with? You guys came out with grape, unflavored, because it used to be just cranberry lychee, but how come that one's gone now? What happened to that one? I love that one.
I know, that's my favorite one too.
That's my
It's
favorite.
coming back.
And it tastes different with different amounts of water,
Yes.
you know?
You know, the new flavors
ice cold water.
were really
I love it.
a big feedback experience for us. When we first launched, we had one flavor, the cranberry lychee, which is great.
Yeah.
And over the few years that it was out on the market, we really wanted to listen to our patients, you know, and nutritionists, dietitians giving us feedback on the ingredients, and also the patient compliance. So having multiple flavors allows for reduction of the flavor fatigue. So even if you love fruit punch, if you take it twice a day for 3 weeks, you may not favor it as much anymore. So having multiple flavors allows people to change it up during the regimen, give different options. And we also remove things like sucralose from our formulation, which there's not, a lot of data on exactly how that will affect patients, but enough people had concerns about it that we were happy to take that out. And
it says sweetener.
It's a sweetener. It's used in.
It's a flavor enhancer. It's a natural flavor enhancer. But
there's some purists out there who just like they don't want anything in it. You know?
Yeah, well, there's a lot of movement towards that, especially with knowing what kind of chemicals are in our food, and I think people just want less of the unknown and what you eat.
The unflavored has been the most popular,
actually.
We
made unflavored,
because you can just mix it right
anything
in.
you want.
Because people don't like stevia, they don't want to worry about sucralose, any extra additive that they deem unnecessary. This really created a medical grade version that you can mix with anything of your preference, savory or sweet. But that's been our most popular, actually, because people are, especially during surgery, they're not looking for GNC or Vitamin Shop. They want a medical grade support to help, a serious orthopedic procedure. And this is something that they can trust and get behind.
I was having a hard time making the unflavored taste good, but I think it depends on what you mix it with. First of all, just don't taste it on its own because it'll shock your tongue like a battery.
Yeah,
but that means it's
unflavored.
Working. That's what I tell people.
Exactly.
Because the amino acids are charged. It's like vitamins and stuff.
I mean, just like NyQuil or DayQuil, it's not a flavor contest. You're going after, the benefits of the supplement. And amino acids by nature all have a different flavor or umami. So some are bitter, some are sulfuric, some are salty or sweet. Each amino acid actually has its own flavor profile.
Yeah.
So the flavored ones, we do our best to work with that. With the unflavored, because it has a bitterness, actually, sometimes leaning into the bitterness rather than trying to mask it is great. So
I put it in a Fairlife Core Power Protein. It was the strawberry one. It tasted really good.
That's
interesting.
Because I've been kind of searching for how to make some of this stuff taste good.
Yeah.
Because it works, but then it's like, how do you get the
I take it twice a day, personally. I make a big pot of hot coffee in the morning.
The mocha, right?
And I heat up my, like an oat milk creamer I have that's sweetened. I put that in there with a packet of the mocha and my coffee in the morning, or the unflavored, actually, because the coffee has enough flavor of its own.
Right. Oh, so the unflavored you can do with coffee?
Yeah. I just put that in my hot coffee with the heated oat milk. Sometimes I'll add a scoop of casein in there just for it's really a breakfast shake. I blend that in the morning.
You can do collagen too or something. Right?
Yeah, whatever your protein.
In my coffee.
I blend that, and sometimes that's all I have until noon, actually. But that one packet, that coffee has almost 40 grams of protein in it.
Do you think are you fasting when you take XR? If you just take XR in the morning and you're fasting, does that break your fast?
It doesn't. So we looked at that.
It doesn't?
It does not.
Interesting.
It doesn't spike your insulin at all.
We did glucose. Some people did some glucose monitor testing.
Which is great. That was one of the things I was very keen on, and I want to make sure it doesn't create an insulin spike.
Especially in the pre-op state when you're fasting.
Yeah, there's no sugar, no carbs.
Yeah.
Well, that's so. I mean, pre-op, it's okay to have carbs as long as it's in a clear form.
Right.
Okay.
Yeah, carbs are okay.
So that's fine. So that's okay.
But you just don't want to spike your blood sugar, right? Are the carbs spiking your blood sugar?
No, the carbs bring your blood sugar up. If you're diabetic, you don't recommend it, but it's maltodextrin. It's a very slow breaking carbohydrate. So it's specifically designed for pre-surgical intake, because you want You don't want a Gatorade before your surgery because you'll get the sugar, you'll get the spike, and then it'll drop right back down. Versus the formulation that's an XR, it's maltodextrin based. It's a larger compound, so it gets broken down very slowly, and that gives you an even keeled response. So you're in a fed state throughout surgery. That really brings down that catabolic state. But you still need the amino acids to bring on the catabolic state. So I think where we're going to go with this next is, first you got to,
amino acids bring on the catabolic state?
The amino acids bring on the anabolic
state. Yeah. I thought you said catabolic for some reason.
The carbohydrates bring down the catabolic state.
Oh, okay.
So that's how they work.
Right. Because it's like rest and digest, hit the insulin, and then you want to use the carbs.
That's right. That's right. But where carbohydrates alone won't trigger an anabolic state. So if you look at the ERAS guidelines carefully and you look at some of their recommendations, they actually recommend pre-op carbohydrate and an amino acid based supplement because you really want to trigger that anabolic state during surgery.
How much liquid is safe to take when you're taking all this stuff before?
200 mLs.
200 mLs. How many ounces is that? It's like 12?
That's what it's 6.
Oh, 6. So not too much. Yeah, so maybe not taking on as much fluid before the surgery.
You want to be hydrated before surgery, actually.
But slowly over time, over maybe 24 to 48 hours.
The recommendation to take...
the osmolality.
Yeah, the recommendation to take the carbohydrate is with 200 mLs of clear fluids.
Each packet? With
each packet, and that's very specific. That's because of the concentration that you want for gastric bypass. So that's very specific. So, you can take your XR whichever way you like, but in order to get gastric motility, the anesthesia, group is really keen on that. And you want a certain concentration so it doesn't sit in your stomach too long or doesn't cause any GI issues.
Right.
So that one is like, there's instructions on that. So when you tell your patients about the carbohydrate, particularly the one in the morning, you want to mix the packet with 200 mLs of water. That will give you the right osmolarity, which is essentially the best ideal concentration, because that will then determine how fast it's going to pass through the gut. Because if you take it within 2 hours of surgery, by the time you hit the operating room and they're doing inducing anesthesia, it's gone. It's through the gut.
Okay. And so can we talk about Muse cells now?
Let's do it.
I'm going to play you a little clip of something that I found. I love these new podcasts where I can learn from surgeons. There's now plastic surgeons. There's a couple guys in Beverly Hills. Seems Lakey, and it's called Forever Young. Plastic Surgeons to the Stars. And so I'm going to play this one.
Muse stem cells came from. First of all, what's a stem cell?
So, the stem cells are progenitor cells. They're cells that, for lack of a better word, they're the cells that create everything else in our body, from skin to hair to nails to everything else. And when we're in the embryonic phase, these stem cells are vibrant and young and really just making everything in our body. And as we age, the stem cells get older, they don't work as well, and we are constantly trying to grasp that this research has been only going on for a finite amount of years. Stress, they wouldn't work as much, be able to last longer and do more in our bodies. We got lucky enough to kind of stumble upon this in a sense.
Yeah. Look, this Japanese research that came out in 2010, she discovered in 2007, was published in 2010, and they're unlike traditional mesenchymal stem cells, right? So the body, mesenchymal stem cells essentially make the structure and function of our body, whereas hematopoietic stem cells, which are the more immune-based red blood cells and white blood cells, those we'll talk about separately. But the reason why the Muse stem cells, which again are multilineage differentiating stress-enduring stem cells, they can survive harsh conditions, differentiate into multiple cell types without any genetic manipulation. Right? So they can be found naturally in bone marrow, peripheral blood, various connective tissues, even in the skin, and they can be isolated for therapeutic use, which albeit is not necessarily easy. These particular cells are put in these stress mediums or where they lack oxygen.
So we can talk about that. You guys said maybe enough of that.
Bioreactors, which can isolate.
This is a brand new stuff that's been coming out. And this review is 2025 by, who was the lead author on this? Mary Dezawa from Japan. But what's so interesting about this is I heard Kim Kardashian was getting stem cell injections for her shoulder. And there was this guy who was talking about, I looked up his website, the guy who did them, and he was talking about these Muse cells and how they're better than mesenchymal stem cells. And the first thing I thought was, this guy doesn't know what he's talking about, obviously, because I don't know what the hell Muse cells are. I had never heard about this. And so I literally looked it up, and that's the article I sent you. Mm-hmm. So these are the macrophage-like, but they're basically these pluripotential, omnipotential stem cells that can differentiate ectoderm, mesoderm, or endoderm, basically the three major cell layers. But they also are very durable, and they have these somatomedin receptors, something like that.
Sound like
sphingosine-1 phosphate receptors. So they're similar to macrophages, but they're not. They're these cells that don't form teratomas. They don't form tumors. So they're non-tumorigenic. So they're past that lineage of like teratomas, but then they can form anything basically. So they're real stem cells in your body. And then I was like, well, where are they most concentrated? And they're actually in the bone marrow. It makes sense. That's where you produce all these cells, and they feed out to your blood. So maybe you get some of them when you're getting PRP, exosomes, little pieces of them, but really it's in the bone marrow. So BMAC is one thing that I've been using now a lot more.
Yeah.
And I'm using it for certain clinical indications that don't meet, hey, you have a full tear, you need a full replacement, you need the full deal. It's not for that. That's not what I'm saying. I've been interested in using BMAC, bone marrow aspirate concentrate, for cases of like partial tears, tendinitis that's just not getting better with other things like maybe even PRP, or they've had cortisone. Hopefully not. I think cortisone is the opposite of what you should be doing if you're trying to get things to heal. So don't do cortisone unless you're on the replacement pathway, pretty much. So I try, or if you're trying to diagnose something, it's minor. But this is a real realm of something that's very, very interesting to me, that I think there is just emerging evidence to show, and enough basic science evidence to show like this stuff might really work.
I mean, I think the ability for us to get our patients to heal is going to be pulling in some of the regenerative capacity. That's what it comes down to. So I mean, I'm big on using bone marrow aspirate, and I use it often, and for a lot of my cases, I use it as an augment to my surgeries. So for my pec, for my distal biceps, rotator cuff, and ACLs. I have
a pec tear coming up, and that was an interesting thing that we were talking about earlier.
I was going to show you.
Maybe we can talk about. You can cue that up and show it to me. But really, it's not about, hey, did it heal? It's, did it fully heal? Did every muscle fiber or heal, or did it have a partial re-tear? So you see this, and then you might need another surgery if you have some of these partial re-tears. But if you can really optimize the healing nutritionally, obviously that's something we can agree is important, but now these interventional augments that you can also add on in those at-risk areas like rotator cuff, pec tears heal, biceps tears heal, but there's partial issues and partial re-tears,
and how fast
and exactly
how fast they heal, right? And so I think
minimizing those risks of re-tears,
and so and the re-tears, there's that's where the patient issue comes in, right? Where their expectations of how fast they want to get back. So, talking about BMAC, so this was a case that I had a pec tear. It's actually a pretty fit physician. So he's like, hey, I want to get back. What can we do? And so to me, there's a lot of different variables that we talk about when it comes to a successful operation. Right. And so we have the discussion about I did a whole metabolic panel on him. We did optimize his vitamin D, but we talked about using mesenchymal stem cells and bone marrow aspirate. So this is when we're doing his surgery. So I always do this, when they're supine, they're laying down. I personally go to the iliac crest.
You get it from the back crest, right? Posterior crest.
Yeah, so you
It's
can,
nice and juicy
That's
back
right.
there.
Yeah, so I go for the iliac crest. We'll take it quite a bit.
That's what the studies show. That's where the highest concentration
right.
of
That's
stem cells are.
Yeah, and I even do that even for my
In your whole
for my
body.
ACLs. I do the same thing. Right.
Out of all the tissue in your body, the highest concentration of stem cells is in your posterior iliac crest.
Yeah.
So that's why BMAC. And now these Muse cells, that's what those Muse cells are too. They can home to the area of injury. So that was the big issue with BMAC. In my head is how does this stuff know where to heal? You just squirt it in there and it just goes everywhere. But if you have cells that find area of injury with the right receptors like macrophages, then they know they can go to where those problems are. And so if you're injecting that locally, it should be able to find its way through there.
So this is to your point. This is another case with a rotator cuff where we'll take the BMAC, the bone marrow aspirate. I'll mix it.
And do you always get it from the hip? Because for a shoulder, I was considering maybe taking it from the humerus.
But you know what? So we didn't. So if you look at the studies, I used to do that.
Yeah.
I no longer do that.
There's just not enough good cells there.
A rotator cuff tear, if you look at the stem cells or the mesenchymal stem cells, the greater tuberosity humeral head is very low. So the last thing you want to do is go to a deficient area. And think about it. You're going to suck out the mesenchymal stem cells from
you're
an
trying
area
to get
that you're
to
trying to
heal.
heal.
Yeah.
That doesn't make
That
any
doesn't
sense.
make sense.
So, so my protocol has been for the rotator cuff, for example, learned that from Gus Mazaka, take the bursal cells. This is the case that we did here. We take the bursa.
I wonder if
we
Gus
take the
is looking
BMAC.
at the Muse cells too. You should talk to him about the Muse cells.
I think we may be getting some Muse cells when we take the bone marrow. We just
I
didn't
think
know they were there.
we definitely are.
Because it's there. We just didn't identify them.
That's exactly right. This is pretty emerging stuff that these studies are showing that's theoretically where the highest concentration would be, but no, there's no tagging or labeling studies.
This is where Luca Podesta is the other guy who I've been learning a lot from, and even
where is he at?
So he's currently living in he's in Florida.
But he practices Florida?
He's in Florida.
In California?
Yeah, but he comes here once in a while.
Oh,
he'll actually be here tomorrow. But
say hi.
With the even the PRP.
You can inject my shoulder.
Yeah, she's great.
I need stem cells, right?
So we'll take.
Oh yeah, we'll do that section later, so you can examine my shoulder. We'll see what kind of treatment I need.
But I'll tell you the other point. We're taking the bone marrow from the hip.
Yeah.
We're taking PRP. Where we're doing.
So take it from the crest.
Take it from the crest.
Yeah.
Actually, I'll do two different spins. So
you get 120.
120
cc's.
Well, I changed. This is now that I'm learning all this stuff as well.
Tell me. This is what I want to know.
So with the PRP
on this show.
So this is all credit to Luca Podesta and Peter Everett. These are the guys that I've been learning from. That these orthobiologic conferences that I'm going to, in addition to the orthopedic surgery conferences. This is where all the cutting stuff is happening, combining the two. So we're taking the the biologics and augmenting it with our repairs. So we'll take PRP, but we'll do a very high leukocyte count.
Because the leukocytes, I feel like, might stimulate some reaction and some pain if you have too many leukocytes.
But this is what we're learning. There are a lot of things in that leukocyte layer. It may be these Muse cells. Okay, and so there's.
So you don't know necessarily where those cells are. That's why we
so their research is showing that you want protein-rich PRP, which takes two different spins, and you actually remove some of the PPP, which is a platelet poor plasma. So as opposed to dumping that, within the platelet poor plasma, there's proteins that acts as a matrix, which is that has fibrin in it that helps with the bone and enthesis healing. So this is why all these PRP studies are very difficult to really compare. They're not apples and apples. They're different
a lot of
preparations.
them they include stem cell or BMAC and PRP.
Or the platelet count is low. How they prepared it, and so I think this is all the nuances that That's why you really can't compare one PRP to the other.
Yeah,
it's the preparation, it's the delivery.
But you're talking about BMAC.
I'm talking about
people are saying PRP.
No,
so PRP is from the blood.
So
BMAC means I got to drill into your hip.
So I'm doing a combination because BMAC.
But it's all from your tissue. That's the only one I'm using is from your tissue, your own tissue.
To me, 100% I'm with you.
Yeah.
Autologous. I use only the patient's own tissue.
You got to give a little to get a little.
The only thing that I use that's not a patient's is sometimes for some of these pec tears or some of these
Sure.
bigger chairs, I'll bring in some extra scaffolds.
That's reasonable.
Okay, so I'll bring in a scaffold, and then, for example, with this rotator cuff that you see here, we create a little putty. So we take the demineralized bone matrix,
DBM.
make a putty, and then I inject that back into the bone intraosseous, and we keep it contained. This is the technique that I'm presenting and we're writing up. Is
For what indication? For pecs?
for rotator cuff,
rotator
particularly,
cuff.
because I'm
Rotator.
injecting it intraosseous. Everyone's putting it on top. They're putting it on top of, this is what Gus Mazak and some of the guys that I've been working with, we're doing the Bursa. They're putting the cocktail of choice
How do you get it in the bone? Do you use the
through the needle.
but is it through the anchor holes that you use for the suture anchors?
So I use this is what I'm showing you right here. So so I come in with my lateral row anchor.
So you use fluoro for this too? So your scope and fluoro?
I'm only using fluoro. This is for the paper that we wrote up. So I'm just to demonstrate where they're going and where they're ending up. So now you can see. I don't know if you ever put PRP or BMAC into a rotator cuff, but where does it go?
I've used it when I scope, and then I'll inject it right where the tear is.
So where do you think it goes?
Where does it go? It goes into every other space other than where you're trying to put it.
My point is it goes right, but that was my problem. So that was the issue.
These are your pictures, yeah?
Yeah. So we come in with the scope.
Is this the first one?
No, this wasn't the first one. This was
This
is one that I just did last week.
No,
That's why
I
it's on
mean
my
like
phone.
which one should I start with? Is this one good?
This is when this is the entry for the lateral portal. I've already done my rotator cuff.
Okay.
Okay, and now I've fixed my lateral row anteriorly. This is my pilot hole for the posterior row.
Okay.
And this is when I put in the
putty.
the combo, the putty.
Oh, because that's not what the BMAC looks like. BMAC is
No.
pretty much just fluid.
Well, that's why we put it together in this putty,
Yeah.
and then I put a dye in, so then you can see where it ends up.
Pack it in.
You see, this one that I go through. So you can see after I insert it.
That one here is what? This is what
So
BMAC?
that's the very end. When I'm done, this is the leftover BMAC that I'll put with the needle into the tendon.
That's left over.
That's-
And then so you just squirt the rest. in
But
there.
you can see, look where it stays. You see how that stays?
So
that
this
stays all
here,
that darkness
here,
and up there and,
and
up top.
here.
Yep, and all that.
Interesting. And so it's kind
It's
of
contained.
It's structurally and contained where it needs to be.
And guess where you want your rotator cuff healing to happen? Right at the enthesis.
Yeah, right at the junction.
I'll make my holes.
It doesn't matter what's way down below. It matters right next to it.
Because once I make my holes and I inject this in, it just kind of seeps up.
Right. Yeah. And sometimes you go in that bone, it's just kind of hollow down below.
So, and that's where you want to go get your stem cells from.
Yeah.
Right? That's why I was like, this doesn't make any sense.
No.
So I've been doing this for about a year and a half now.
Yeah, well, that makes sense. Well, I'm going to stick to the crest for sure. And the next thing I'm trying to figure out is really when to use BMAC. So I think that right now,
If cost wasn't an issue, the question would be,
it's definitely partly an
that's the
issue.
problem. So
Otherwise, I do recommend it
Yeah.
if I think it will help someone, and then they have to figure out if they're going to pay for it because it's expensive and it's all cash.
I think it's expensive. I think a rotator cuff re-tear is more expensive.
Sure.
I think we're not. There's good studies coming out with Brian Cole did a recent study looking at BMAC with cuffs, and there's good evidence mounting. I think we still need to do more. I'm very excited about this technique actually.
Well, this is cool.
Because I think it's putting it in the right place. As far as just putting it in a place that's going to hold it there better.
Yeah.
And so I think it's the delivery is just as important as what we're putting in.
Well, it's definitely true, and a lot of times you can't see what's underneath. You just know what looks on top and how things go. But what's really cool is figuring out ways that we can use this stuff, because one of the most powerful decisions people can make in their life is the decision to undergo surgery. So people will, if they can avoid surgery, I give them the options if it's a safe thing to do to avoid surgery, because some things are not necessarily safe to avoid because you're higher risk potentially with deterioration over time, but that has to be their decision. Especially with elective surgery, you're not going to die, but you might have deterioration in function that's not fixable that you can never get to that full extent. Like
That's right.
for a rotator cuff tear that degenerates versus one that heals and has a perfect outcome. That was one thing that changed my idea of how a surgeon can intervene with something that is not just fixing it for a while. It may totally change their outcome on their shoulder versus, hey, I didn't really know, he did therapy, he whatever, got bigger, and now he's got fatty degeneration and it'll never heal.
Yeah.
Now he needs a reverse. So that's where the knowledge of knowing, of being able to teach the patient of like they can intervene on those things that will matter and those things that'll help. Like ice, will it matter in a year if you used ice? Like the reality is probably not.
So it's interesting you brought up ice. So ice is one of those.
But it'll definitely help those first couple of weeks, and
It'll help-
if you
it'll-
avoid a
It'll help
problem,
them feel better. It'll help them feel better. I don't know if it's
everything
actually
translates indirectly. It's like you might be on less pain medicine. Then you're going to be on less likely to have falls. You get those indirect benefits of just doing all the right thing, and everything goes well. That's why I just always go back to that. It's like just try to do perfect surgery. You guys do all the right thing, but it's just you got to play the cards and play those risk profiles.
I'll tell you something interesting on ice. I think the pendulum is going to swing.
On ice.
Because I'll tell you, some of the guys who are really crazy with looking at it, healthy inflammation and healing, you want a little bit of healthy healing.
Uh-huh.
And, I don't know what your thoughts are with NSAIDs. Do you use NSAIDs after surgery?
Just for the short term.
Just for the short term, right?
For
Okay.
5
Will
days.
you use NSAIDs if you give someone PRP?
No.
If you're going to have PRP tomorrow, are you going to use NSAIDs?
No.
Okay, so if you're going to put, PRP or BMAC in your patient who's going to have surgery, are you going to give him NSAIDs? Are you going to tell the anesthesiologist?
Not before.
But what about after?
Yeah, it's just if they need them a little bit, but not for a long time.
So this is a hard decision because I'm with you. I want my patients to get the ice because I want them to feel better.
Yeah.
I want them to take less narcotics.
Right.
But if you look at what's happening to the body physiologically, if you make that shoulder frozen like ice, guess what they're not getting?
Inflammation.
They're not getting inflammation.
Yeah.
You want a little bit of inflammation. It's about modulating inflammation. So you don't want excess inflammation. But this is why, the whole idea of wanting leukocyte poor because it's too inflammatory, I think there's a good debate on that.
Mm-hmm.
Aren't they using heat on some people too?
Yeah. So some of the guys, including myself now, I've shifted. So if I do a PRP injection on someone, I don't give them NSAIDs before. I don't give them NSAIDs after. And I don't use ice. I actually use heat now. So in the ACL world too, because of the inflammatory issues that we see, people are avoiding ice when we used to really use them and then maybe bring it on later because you want a little bit. So I think this is very debatable. And I think that there's still a lot of people who are like ice. And listen, I love ice. I jump into a cold plunge in the mornings, right? But I think as we're learning more, I think our philosophy on how much ice and when to ice is going to change. And I make it very simple for myself. If you've ever been outside and freezing cold, you stick your hand in in ice, or what happens to your finger, right? You cut off the circulation, right? It gets cold, right? Your finger turns blue.
Mm-hmm.
You're cutting off circulation, right? Mm-hmm. So if you're decreasing circulation to your area that you want to heal and you want to bring in all this stuff, that's counterintuitive. So now I'm starting to actually question, do I really want all my patients on ice? So I've started to back off a little bit. So I definitely don't use NSAIDs. I tell the anesthesiologist, no Toradol in this one, right? And especially if I'm doing these orthobiologic procedures that I'm doing more and more of. Mm-hmm. I'm not pushing ice like I used to. Mm-hmm. I don't have all the answers, but I'm just sharing with you.
What about because you shared with me exercising before PRP?
Yes.
And I've been telling people that, and the more I read about it, the more it makes sense that it upregulates your bone marrow production of these
just
regulatory
30 minutes.
cells.
30 minutes. That was a study that was done.
Bone marrow and in your peripheral
Rana
blood.
Parsa did that study.
Andrew, it was on Andrew's clinic. Yeah, Dr. Rana Parsa did that, and that was done at Andrew's. So really, your body's intrinsic ability to kind of kick up or decrease the stuff.
So how much exercise was needed?
It was 30 minutes on a bike, and when they looked at the markers of those patients within 30 minutes of exercise, exercise does all. That's why throughout this podcast I would tell you, of all the things, this is one thing you got to do for all these health span. Mm-hmm. It's exercise.
I tell my patients to exercise the morning that they come in for a PRP shot, just to get some cardio. hopefully not too sweaty, but just to get their heart rate beating a little bit and to upregulate.
I think we
things.
need to learn more about it, but I think the physiological stress of exercise is something that we can kind of tag on.
Well, same with when I tell them to take XR too before BMAC and before PRP, because they should stimulate their body's production of those things, of those factors, because it's a cut in time where we come in and we just get what we can, and then I put it back in, and then that's it. But if I come in and you have a full tank and all the things you need, you're gonna have a higher yield. And a better yield of better stimulatory cells. The whole purpose is good cells, not just any cells.
We work with a lot of orthobiologics non-operative surgeons that do the XR surgical regimen for the PRP as well.
That's what I'm doing.
Yeah.
I'm recommending it.
Yeah, so the orthobiologics.
Optimizing the environment.
Yeah.
You know,
especially for biologics, because you're relying on
that's all you got.
Of them.
You are relying on the patient's biological intrinsic kind of reservoir. You're tapping into that. You're tapping into their kind of, storage system. And you say, okay, let me pull what I can get from you. I'm going to take what I can get from you. It's your own tissue, and I'm just going to concentrate it, and I'm going to give it back to you.
Yeah.
Right?
I say I harness the body's natural healing potential.
That's it? That's exactly
Concentrate it and inject it right back in. That's almost exactly what I say.
Right. And so if that patient's, healthier, and they're tanked up. So there's a really compelling study that was done with amino acids for 1 week before total knee arthroplasty. This was a Dreyer's group. And they gave patients amino acids for 1 week before the total knee arthroplasty. And they followed them for 2 weeks and then 2 weeks after. Same regimen, right? But what was interesting is at the time of the knee arthroplasty, when they opened up to do the surgery, they biopsied the tissue, the muscle tissue. And they looked at the difference in muscle tissue stem cells, which are called satellite cells. The satellite cells of patients who were supplemented with amino acids for 1 week before surgery.
Upregulated.
They had a higher amount of satellite stem cells, which means the body responds. You kind of build the resilience, you tank them up. Those patients went on to have less muscle loss and faster functional recovery. So it's really exciting to see we have some mechanistic, basic science studies here that are now translating into our clinical practice. So, that's why I told you one of our studies that we're also looking at how much of the tissue that we're taking into orthobiologics cases is going to be augmented by supplementation in that group. And and maybe we'll see something similar to what we saw.
Is there anything that shows what percentage of an effect change with those types of supplement stimulation for either BMAC or for PRP?
No one's
studies?
No one's looked at this yet.
Like a threshold effect of when it can hit, and maybe if you do a lot for a certain time, kind of like loading with creatine, where you can get everything.
These are all great. This is
super
where we're
interesting
at.
field right now.
Yeah, especially if you're like you see someone today, and they're like, look, my shoulder hurts. I got a posterior rotator cuff tear, and I don't want surgery. It's 30-40%, but it's hurting me. You're like, look, the compression's not going to really work. I know it's torn, but you're not there for surgery. They don't want surgery. You're like, okay, now I'm going to harness your own tissue.
Yeah.
That you want that patient to be healthy and tanked up, right? So this is where we got to do the study.
I find
we work with Dr. Ariana Demers, who does orthobiologics, and her regimen, actually, she does 28 days. So she does the 3-week program before the PRP.
Yeah.
She has a full 1-month pre-optimization program for her patients before that. And they're doing diet, exercise, nutritional optimization with XR for a full 28 to 30 days before they even go in before their procedure.
So she got a hold of them for a while. She's regimented that way.
They're extremely optimized before they ever go in.
I mean, it makes sense. It makes sense. And, the same way we prehab I prehab my patients, right? I mean, the more they are kind of thinking about it, they're fit about, they're getting their fitness level to a point that we want. They're thinking about the muscles that they can use.
Sure.
And then get their nutrition up, get their vitamin D. I mean, these are all the different variables.
They already feel better before they even have their procedure.
Well, I've seen improvement in pain too after the procedure. Sometimes you can get soreness from PRP. It can sting. Sometimes it doesn't really have that same effect. Since I've been getting people tanked up with the supplements ahead of time, and then the recovery afterwards, they seem to not have as much pain after the procedure either.
It's really interesting.
So it could be really giving them what they need.
The pain, the pain aspect has been really interesting, and I think we need to still understand that more. But I've been hearing that from a lot of surgeons saying, hey, you know what? The patient complaining of less pain.
Less pain. I
You
see it
know,
consistently.
And
With supplementation.
I think we need to still understand why that is. I think there may be some inflammatory process that we're modulating. Again, you don't want to kill that inflammatory process, but I think you don't want too much inflammation.
We have a lot of patients that say they took it, and then once they were on the regimen, their arthritis went away, and when they stopped the program, it came back. So they asked if they could get back on XR.
Yeah, that's kind of
So I'm gonna
benefit.
so I'm gonna tell you this. This is something that is really like deep.
Join the XR club, folks.
But so I'll tell you something that's really, really deep into the formulation. That now that we're kind of talking about the stuff about pain and inflammation, so we talked about creatine. You know, that's been known for a while. That's in XR, and that has some of the benefits that we talked about.
This is not a podcast about XR either. You know, I didn't have you on as like a promotional for XR.
No.
I just,
But talking about
not
some
a
of the
sponsor
things.
yet. You guys gonna sponsor it though, right? So,
I think now we have to.
Okay, yeah. Now you have to after today.
Now I have to. But just, you know, that you're making me think about some of the variables and what leads to pain reduction. And so,
especially with all these studies that we got to do in the future. Very near future.
So, you know, I think we talked about creatine, we talked about HMB.
I got a guy, by the way. I got a good research guy. He works with me now.
Okay.
Sina, if you're watching, you better be watching my podcast. He's from Harvard. He's really smart. And we have some cool stuff we're working on for just gathering data, pumping out research for independent orthopedic surgeons to just look at all your data. XR is part of that. Hey, XR, you can click a little box. Did you take XR 1 week, 3 weeks, or not? And then that way you can look at your independent data and see if you're having those pain response effects. So I'll get you in touch with him, and he's a guy that I want to actually introduce you to, so that way we can talk about some of the studies that we've got running and going on. So sorry to cut you off.
No, it's okay. But so we talked about creatine and we talked about HMB.
What's in XR and all
right.
Yeah.
So the other variable that decreases pain and inflammation that people really don't talk about, there's a combination of cysteine and theanine. The cysteine-theanine combination is anti-inflammatory, and it modulates a lot of the excess inflammation that you see after surgery and after exercise. So this is something that, you know, I learned from.
And the relative levels of each, not just necessarily one or the other in a certain amount. It's the relative levels too, or that doesn't matter?
The combination of the amino acids, cysteine and theanine, at a very specific dose.
A dose, okay.
At that dose, okay. So those studies were shown in both clinical studies in surgical patients, as well as athletes. So,
and what kind of effect it had? Anti-inflammatory?
So they took two groups of athletes. They took runners and they took bodybuilders. The reason they chose those two is because you can really specifically look at the amount of running distance and time, so you can really know exactly how hard they work. And with bodybuilders, you can say how many times a week, how many sets, how many reps. So they took these elite runners and these elite bodybuilders and said, okay, what do you guys normally do? And they asked them to double their routine. And then what happened to these athletes? They got infections, they got burned out, and they checked their inflammatory levels, interleukin-6, some things that we look for. The patients that were given, or the participants that were given the cysteine-theanine combination, they had significantly less inflammatory response. And so that combination was also put in patients who had GI surgery. And when they checked the laboratory values of those patients after surgery, those laboratory markers that for excess inflammation was also decreased. That's where they saw less pain. That's why it's a very important component of XR. So we put that combination in XR. So you kind of really hit all these different variables.
So maybe through cysteine-theanine pathways, it could be modulating pain.
So I think it's coming through the cysteine-theanine anti-inflammatory or modulating the inflammation. That's where it's coming in.
Maybe, yeah. And especially because we know through the inflammation pathways with bradykinin, you know, those types of receptor pathways, that inflammation gets increased and then it stimulates all kinds of different cytokines and pathways for not just one area, but pretty much throughout the whole body in different ways. And then things like cutting inflammation, you know, you got to be careful with your effect on those things. Like you said, NSAIDs, you know, those are non-steroidal anti-inflammatory drugs.
Yeah.
So those are going to to have a significant effect on pathways and how your body uses inflammation to either recover or to heal.
I mean, the
But things
spine
just
guys,
go,
right? The
things go
spine
out of
guys don't-
control. It's too much inflammation. It causes lack. You can't heal with all this inflammation. So that's why when people hear this, like, not enough inflammation, too much inflammation, but too much inflammation we know for sure is a bad thing. Chronic health
Chronic.
disease.
That's the key.
Chronic
That's the exact
overinflammation.
word.
That
Chronic
will cause problems.
hyperinflammation
Yeah, it's bad.
is a problem.
Yeah, it's like
Right.
being at war all the time. You know, it's just like you
Hey.
can't let things recover because everything is just stimulated and you're just using up all the resources to deal with or cause even all the inflammation because all the cells that are active with inflammation, right? It's an immune response.
That's right. So that's. I'll send you the paper so you can take a look at it.
Okay. Okay. Cysteine and theanine is stress-reducing amino acids. Perioperative use for early recovery after surgical stress. Cool. How come all these studies are out of Japan?
Because great question. Because the Japanese were the first really to understand the use of amino acids and using umami. The biggest company that makes amino acids is from Japan, right? So they've been working on flavoring.
Umami's a company?
Umami's a
Or
flavor.
you mean umami flavor?
Umami's a flavor.
like
yeah.
that's a taste receptor, right?
It's like
You can
it's
taste
like
that?
the seventh taste, right? And
Where
so-
you taste amino acids.
Yeah, and so soy sauce, so Ajinomoto, it's one of the companies that we get our amino acids from. These guys have used food as medicine for a really long time, so the Japanese are way ahead on this.
Like what kind of foods?
I'm just saying in general.
Oh, just using food
I'm saying
to treat.
such as this, such as cysteine and theanine.
Oh, I see what you're saying.
Like amino acid and soy-based products.
Based on soy.
Yeah, and so all the studies I
Where
was
the amino
referring.
acids
Is
come
cysteine
from.
and theanine in soy?
No, it's not in soy.
No.
No. But what I was just
Some
saying.
of the amino acids come
Like
from
soy-based
No, I was
amino
just saying
acids.
soy sauce. I was saying soy sauce, and then all these things were essentially coming from the Japanese flavoring
Diet and their
the diet, right.
flavoring and how the food that they eat. and
All those
that.
exercise-induced
see.
muscle damage studies that I refer to,
Right.
a lot of them were done by Japanese. That's one thing. They're way ahead. They've been using foods, i.e. amino acids, for a long time because once they kind of broke down the amino acids, not just for flavoring, they realized it had other benefits.
I see. So is there anything else in XR that makes it special other than the cysteine? Because it has the branched chain amino acids.
So those branched chain amino acids, arginine, glutamine, these are vasodilators. These are for the immune system, the immune response.
Yeah.
Leucine's, really the trigger for muscle protein synthesis. So, when I was like looking at what do we want as orthopedic surgeons, it was muscle, bone, and collagen synthesis. It's and modulating inflammation. It was really those four things. I was like, this is what we want to do. And so I was kind of pulling all these different supplements from my patients individually. And patients were like, Doc, I feel better. And I would see my patients do better. But I was like, this is crazy. I can't have them go to GNC and get 5 different things. So I had a long list of things on Amazon. And they're like, how do I know this one's good? And how do I know this one's bad? And I was like, I don't know. So this is why I was like, okay, let's do it ourselves. Let's do the studying. Let's do the testing. Let's get it done right. Let's get the right dosing. I want to make sure it's NSF or sports certified. We're dealing with high-level professional athletes. That's how it started.
And then what was Gray's involvement with that? Because you're the COO of the company, right? And so
I mean, look,
obviously we know Gray is essential to the whole company.
There's no way this
There's
would have
no
been.
company
No way.
without Gray.
There's absolutely not.
But-
listen, I'm in the OR.
course.
I'm in the OR.
You can't be doing everything.
No. I'm in the OR. I like to
And
geek
be
out.
in the OR.
I like to geek out on this stuff for sure. I mean, I've had a background with skeletal metabolism and
Yeah.
stuff. But
Plus you got to work out.
plus I got
And
to
you got to
work
cold
out.
plunge and you got,
So then everything else is her.
So you had the idea, you started treating patients, but that was before you met Gray?
Yeah.
Okay. So then, but you had this idea and you were kind of working through the formulation over time. And then you got to a point where it was something that was a certain dose and you were ready to put it.
He used to have a blog on his original website
Blogging.
called top 10 surgeon recommended supplements for recovery.
Yeah.
With all these links to Amazon.
Yeah.
And patients were purchasing it, but if you bought everything on the list, it would be $600
was
and
more
you were a
expensive.
mad scientist at home.
Yeah.
Yeah.
Because
You
then you
know,
got all this extra of each
Yeah.
one
Yeah.
and stuff. Yeah.
Yeah.
Right.
That's
Okay.
exactly what it
So
was.
when we put our heads together on the idea, it was how to legitimize this in a medical grade.
Yeah. So it was formulated, but
way.
not like ready to go for.
He knew the
whatever
ingredients,
it is today.
but creating it in a way that was going to stick for orthopedic surgery or be hospital ready and
Totally.
patient ready is
Yeah.
something very different,
Yeah.
And FDA, I think what a lot of people don't realize, doesn't govern dietary supplements. So you can go to GNC, Vitamin Shop, you can even go to Erewhon and buy the most expensive supplement there, and you have no idea what's in that capsule, what's in that bottle is matching the label. And that's a big concern. And
And there's so many supplements
And
out there,
that
so
was-
many
yeah.
companies,
I
so
was
many
so
people
s-
making.
and
They're like, oh my god,
and
another
that was
supplement.
I'm
the
like,
thing.
no wonder surgeons
Nobody
never
wants to hear another
recommended
supplement.
before.
Yeah.
Because how could you trust
And
something?
that was the thing. I was very skeptical. I was like, I don't know what's out there. I've researched what I know, but then I don't even know if I'm sending my patients to Amazon or GNC. Are they really getting what they're getting? So when I was thinking about this, I was like, well, let me talk to I should, reach out to the FDA. I said, look, I'm an orthopedic surgeon. I want to use it in hospitals and patients. And can you help? And they're like, go to the NSF for sport. They're like the best who can do this because they're already taking care of high level athletes. And
What does NSF stand for?
so NSF for sport is a third party.
It's like a testing
It's
organization.
a testing
right?
organization.
Yeah.
And so they have been really great in being able to validate the fact that, what we want is actually in the product. And this has given us a lot of peace of mind as surgeons. You want to make sure you're giving your patients, the right thing.
Mm-hmm.
And so this process obviously took a long time, but
These guys, NSF.
yeah. So NSF has different
And there's
subsections.
NSF
Oh,
for
nutrition.
NSFforsport.com.
Oh, it's for sport.
So NSF regulates a lot of different national safety, things, everything from water, to different things that can affect the public.
Uh-huh.
And so they created a specific part of their organization
Yeah.
just for dietary supplementation.
That's right.
This one's certified
Yeah.
for sport.
So NSF, they test for over 290 banned substances for any of the professional teams.
Yeah, this is the label I see on
That's
the
right.
Exactly.
This is huge.
They
This
also
is huge.
test for everything from mold, contaminants, and they're really big about every dose
This
must match that label.
Because
It has to meet those standards to
Oh,
get
yeah.
the label.
Absolutely.
And this is why we work with a lot of the NFL and the professional level athletes. They can't take a supplement unless it's been certified by NSF for Sport, right? It's got to have the third party testing. So for us, this has been great because now I have peace of mind knowing, what I'm giving my patients or what I'm recommending is something that is safe.
Yeah. And we work with Major League Baseball, and all the team doctors for most of MLB, along with NHL, Olympic teams, NFL. And for them, it's been a huge relief to have something that can be a go-to for their patients, athletes when they're injured. They trust it. They can get behind it. We're at most of the training facilities. They're using it non-operatively for overtraining, injury recovery, physical therapy. It's been great to have that NSF backing, and for surgeons just to sleep at night. If it's your grandmother that's 100 years old with a hip fracture, you want to know you're giving her something that's medical grade, or
Right.
your kid with an ACL from soccer. You want to make sure
It meets the standards.
it's safe first and foremost for
Yeah.
patients. It is really what I think opens that door to feel confident in what you're recommending. The ingredients are there, but if it's a off-label brand with nobody regulating that, they're probably not getting the clinical benefit.
Yeah. And then do you have relationships with a lot of athletes, or in terms of like how this type of supplement can be used for? We talked a little bit about like athletic performance and recovery, but I know like you do jujitsu, right? And there's some history there. I remember you telling me some stories. But do you still train? Do you still train jujitsu, or do you do mostly weightlifting? And
I
things
do a
like
lot
that
of
now?
weightlifting.
Yeah.
I'm big into Bikram yoga.
Yoga.
Anything we can do that's active and fun, just as a lifestyle is great. I'm not training regularly now. Actually, our CFO just got her black belt,
Right,
which is
yeah.
great.
You just don't- yeah.
Beast. Right?
I'm very fortunate to have started with the Gracies and the Machados. Higan Machado is my first teacher, and it is really the one sport where everybody's injured, and when you go in to train, you're like, oh, today it's my wrist, or if you could
always
watch
something.
my ankle, and so everybody's injured, but everybody wants to get back and train.
Right.
And this is something. I know Daphne, she used to bruise really easily, and now she's taking it after every time she trains.
Yeah, pretty much. I mean, I'm pretty much taking it after I train. That's why it was like kind of like working out. I mean, it's a similar thing, and you just feel a lot better.
I mean, it's a really intense sport, so
Very
anytime you're overtraining or you have that higher metabolic demand and need, for amino acids or for recovery, whatever it is, this is where XR really comes into play. Not necessarily as just everyday protein shake, but for those overtraining days especially, this is where that really comes in.
Yeah, and that's a really interesting thing too. Just thinking about how we can, optimize based on our performance.
Yeah.
Especially if you're just redlining all the time.
Like I know if we're gonna go do a Bikram yoga class, it's so intense. I'm hallucinating and forget my name half the time in the class. And jiu-jitsu's the same. You raise your hand to roll again, and you're like, oh my God, I don't know if I'm gonna survive, but I'm going back in for my 5 to 10 minute round. This is the time where, I'm probably going to carb load an hour before that class, maybe jiu-jitsu or Bikram, because I don't need a full belly.
Yeah, I like eating before.
But I need reserves.
I need to eat something before.
So you can carb load before your training or your, whatever your exercise is, and then you've got XR right after, so you're recovering, so you can go back to class tomorrow.
Yeah.
And still feel good to get back at it.
Right. And I'm going to be competing at IBJJF. So that's
and,
one of those things where you want to, you're gearing up the competition.
And maybe
training.
you're cutting weight, right?
I have been cutting
so
weight.
70
exactly
calories,
right.
70 calories per
questions.
packet is huge because
Right.
your protein powder is 250 calories per scoop.
Yeah,
so if you want to
exactly.
keep the nutrients, keep the muscle, but stay lean.
Yeah, that's what's been really difficult.
This is huge for
Keeping
that.
the muscle, but losing, getting
so
leaner.
that's where I think it's really helpful, because when you have a calorie deficit, then you're going to lose muscle. But you're trying to minimize the muscle loss. And this is where having something like an anti-catabolic supplement is really going to help. And so this is where, for me, I used to fast and do just a water fast or black coffee. Now I'll just if I do the fast, it'll be with XR on board. That way I'm getting a lot of the benefits of fasting. I'm not spiking my insulin. I'm not getting, much calories to have a meaningful effect. But more importantly, I'm not losing the muscle. And I think, putting on muscle as you get older is not easy.
And keeping it.
And keeping it.
Yeah.
And so I think that's where it becomes really kind of a strategy, so this is, we wrote on this. There's a blog that we wrote on. It's called, keep the muscle, lose the fat. Right.
Oh, I'm a fan of the muscle.
And that was for GPL1s, because a lot of the people who are taking these GPL1s, they lose a lot of weight, but that weight is significantly out of his muscle. So same with fasting. You have these benefits, but then
you might be losing total body mass.
You're losing body mass,
muscle and fat.
But if you look at the composition, it's not ideal,
right?
And then the other question you asked about performance, right? So performance, to me, if you look critically at performance, if you're trying to get better over that 6-month period, you got something coming up in how long is it?
It's end of August.
Okay.
Yeah.
So
not too much longer.
Okay,
but I've been training.
Okay. So let's say whatever, you got 3 months, 6 months, a year, right?
Yeah.
And you have a finite amount of time that you have to train for. So if you break it down, how many sessions are you getting in that time? And in order to make progress, you really have to kind of outperform your own performance from the last time.
That's
right?
true. Yeah.
So in order to actually,
otherwise you're kind of stagnant or plateauing.
Right. So in order not to be stagnant, then you have to perform wherever you do, then rest adequately.
Yeah.
So then you can build on that, right? And in order to make that progress, you got to continue to recover, rest, and then build on that, right? Nowadays, there's no problem with training hard. Most athletes are training hard, and they're overtraining.
Yeah.
The problem is they're under recovering.
Yes.
So what ends up happening is either they get injured or they haven't recovered adequately to then put on the actual building block on that next gain. So really what ends up happening is that finite amount of time that you have, if you haven't recovered adequately, then you're not going to get your performance to where you want to be in that finite amount of time. This is where cutting down on the EIDM, the muscle damage over that period of, 3 months, 6 months can have a meaningful difference when you actually hit your target when you want to compete.
Right.
So this is where you can use the strategy of supplementation to recover more efficiently so that you can build your performance.
What was so? What do you fast every day?
No, I'll probably, there are 3 to 4 days a week that, I'll skip meals, and then I'll have XR.
So maybe half of the week or almost.
Yeah, it just depends. And, I also just listen to my body. You know what I mean? Like,
yeah.
If I have like a couple of days where I ate bad, then
might need to fast a little bit.
Yeah, and I enjoy it.
And that's not for vanity purpose. I mean, it's for balance and homeostasis.
Sometimes I feel good. Sometimes I feel
maybe
good.
a little vanity. But,
both.
But sometimes you're a little heavy. I was actually building a lot, and my weight was going up because I was training, I was working out, I was taking XR, but my diet I wasn't really being careful with. It
wasn't clean.
So I was gaining a lot of mass, but I was strong, and jiu-jitsu was going great because I was big and strong. Yeah. But I was like getting way too big, and I actually gained a lot of muscle in my legs and good places.
That's good.
But then now I have to kind of cut a bit because I realized I gotta you have to manage that. You gotta balance your weight because you could just be basically bulking up and building. It's a real thing. But it's just nice to see results when you keep working out. It takes at least 2 weeks to see some kind of something, and then 6 weeks to see I think any significant change. So that way, if you have competitions coming up, you only have so much time, and that kind of puts me into gear too. But now I was able to see kind of some things budge with some of getting rid of some of the alcohol, which by the way, I have this lovely gift here from one of my patients. See, that's the benefit of drinking wonderful tequila on my podcast. Is your patients know that listen to your podcast.
I got to tell my patients
what kind of tequila you like.
They keep bringing me wine, and I'm like, this is a little bit better.
Yeah.
To let them know you like mezcal.
Well, I was out of Mandala tequila, which
what a beautiful bottle.
This is a beautiful
great
bottle
gift
from one of my wonderful surgical patients.
Yeah,
His
awesome.
lovely wife, by the way, who now was interested in taking XR. So hopefully she's going to listen to the show. But let's crack this baby open and have a little toast. Are you okay with some tequila?
Absolutely. Yeah.
Are you on call today?
No.
No, you're okay now.
yesterday.
Yeah, you're clear. So we were kind of talking about some of the ways that alcohol can really get in the way of some of these metabolic pathways. And you told me you were the 80-20 rule.
Yeah.
Where he sent me a nice little thank you card too at the bottle, so I appreciate that. Thank you, by the way. And so the 80-20 rule, which is 80% good and 20% you can kind of mess around a little bit, right? Like have a little tequila or this and that.
Yeah, I think in life you got to enjoy.
You want some? Do you want some, Gray?
Yes, please.
Sure, let's pour it up. So that's about enjoyment, but it's maybe about some balance too. So that way you can kind of realize some of the mistakes you make by drinking too much tequila sometimes, if you get a headache or something. But this one's reposado, so it's going to be nice and delicious. This is my favorite tequila, by the way. I think they're supposed to have a bottle for me coming that has LA Shoulder Podcast on it.
No way.
Yeah, I haven't seen it yet, and I ran out of tequila, so I was about to start drinking some bourbon tonight. But fortunately, I have a nice bottle here. And so, cheers.
This one?
Yeah, either one. They're about the same.
Cheers.
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 So this is to the 20%.
Yeah. Thanks for having us on, Matt. Thank you.
Oh yeah, it's delicious. But it's good, right? You remember this one?
Yeah.
Yeah, it's good. It's like it's like tequila candy. And so I think a little bit it's okay to mess around a little bit, like you said. I've been thinking about a lot of the things you taught me that first episode, but at the time I was still going through like shoulder surgery and I was kind of recovering, and it takes time to just get through that, and then time to learn. That must have
been hard, man.
Oh, it was super hard. It was super hard. But as long as you know, hey, it's going to be a long road. You just go by every about 3 months. You're like, as long as I'm not getting worse in 3 months, things are getting hopefully better every 3 months. Or at least not getting worse. But once you can start to see, okay, things are healed and now you can start building, that's when you're like, okay, things are going really well. And I used to hear that from my patients. So I was confident, as long as I felt like I was progressing, that my building phase could start. So that's kind of where I was at when I told you I got like too big, because you're kind of sitting around from surgery and all of that stuff. But it's just, it's a hard thing to gauge, that 80-20 rule. Unless you're just really, your mentality is 80% of the time, I'm really doing the right thing.
It's pretty much, you got to be on 100% until you go to a podcast.
Until you slip. Yeah.
Something.
Yeah, right? It's like, I was at 10%, now I'm 20.
No,
I lost it.
But I think, in life, you got to have that balance.
Cheers to 20%, 10%.
Yeah.
Cheers.
Yeah, cheers to that again.
So you were at 10% and now we're at 15%.
It's all good.
No, so you've been. I mean, that's something that you use in your diet. You use that in it. It's pretty much your diet or lifestyle.
I think in life, like plus those 80%. It's not like I'm suffering. I enjoy eating healthy. I enjoy exercising. It's not like I'm miserable. And I think like I even when it comes to like diet, like I like what I eat. It's not by force. Like if there are some cheat meals, but I think once you get into the habit of things, it's just the way you are.
So I was going to ask you that. So it's more of a habit, and then
I think if you have a
things.
good foundation, like at home, I'm probably not going to have fried foods. I'm not going to have cake in the fridge. I'm not going to have a bunch of candy. But if I go to a birthday party on the weekend, I'm going to have a slice of birthday
Right, so
cake
you don't have to say
and
no.
a glass of champagne.
Mm-hmm.
But these are probably not things I'm stocking in my home all the time.
Yeah.
So then when you go out to a restaurant, you enjoy the creme brulee at dessert and you have a good time with your friends, But
Yeah.
it's just, this is not every night I need to have this dessert thing at home or whatever. Then it really is a treat. It really is something you look forward to, and it's exciting, and you're
Right.
like, wow, this is incredible. Like you appreciate it in a different way when it is still a treat, not your everyday.
Yeah, and you keep it that way too. Like you look
Yeah.
forward to maybe a little treat, and
Then
just
it's
keep it that way.
exciting.
Yeah,
Then you feel like you're indulging in like this great thing.
sure. So one of my buddies who I do jiu-jitsu with, he was on my last show. He was at ZoFit. He was telling me, he's a personal trainer, fitness guy. He's real fit. He was telling me, I only put 2 beers in my fridge because that way, if I want more than 2 beers, I got to drink a warm one, and I'm not going to do it.
Yeah.
So that way, it's like that is amazing. It's just like a personal trap in your own refrigerator to
have
not
to
let you
You gotta
fall off
set
the
yourself
edge.
up for success.
Yeah. So and it's like the little ways you look at things. It's like those little steps, and then just feeling better too. So a big part of this is just getting my patients feeling better, me feeling better, and kind of getting in something that's more manageable. So like diet, we were talking about. I was talking about whether or not you fast. So you would go maybe until say like noon or something. You have, or you maybe have a XR when you feel like you need to, or after you work out or something like that.
So I mean, I think a real. So I have. Like I was telling you, I think there's benefits of fasting. So, and I don't think you need to do it too often.
Yeah, but I think you should fast. There was literature that recently came out showing that the 36 hours of fasting, which seems like that's a long time.
That's when you really kick in.
But past that, it doesn't really help much. Is from I recently heard that those effects don't carry on. The fasting effects will continue, but 36 hours was the key.
But
I've never fasted that long.
But
That's a long time.
you gotta hit at least 16 to 18 hours.
For the threshold, right?
The threshold.
But then the benefits continue to increase until you hit 36 hours.
Then I think after that, I mean, when I tried it for more than 2 days, my sleep actually.
You did it for more than 2 days?
The hardest thing for me was sleep.
Yeah.
Was sleep. I had a hard time going to sleep hungry.
Yeah, me too. When I need to eat, or if I after training, if I haven't eaten, it's really hard for me to fall asleep, and I need something in my tummy.
And
it needs to feel full.
By the way, that's another.
So you fasted for 2 days and you couldn't sleep.
It just messed up my. And it's like it was more of a mental thing.
Yeah.
And some physical. I liked the after. I mean, it's hard when you miss a meal.
Mm-hmm.
Like. It's like I'm used to eating routinely, like every few hours. That's just, but
that's what's interesting. That's kind of why I asked you, because bodybuilder guys are used to eating just regularly. You're just eating the right thing.
They're
all
also
the time.
working out regularly. I think if you're not a fitness enthusiast and you just have a desk job, 9 to 5, you're not that active, and you're eating every 2 to 3 hours,
that could be a problem.
then you probably
the
should.
days I don't train, then I'm not as hungry.
Right.
For sure.
Uh-huh.
But
are you eating eggs in the morning?
You probably eat less too.
No, I'm eating. I just you kind of gauge it.
It's like more relative to your activity.
Yeah.
If you can.
I just find that if I'm paying attention to what I'm eating and just thinking about it a little more, I'm way healthier. Like right now, or if I just kind of fast every now and then, even just fasting puts me in this kind of, let me think about my food a little bit more. Otherwise, I'm just kind of getting up and eating and going to this meeting and then eating. It's kind of this repetitive cycle that doesn't feel healthy until you break the cycle.
I think fasting
fast every
is
now and then.
good.
I think so too.
I think it gives your GI system
a break. Yeah, sometimes we need a break.
Yeah,
go for a run, take a break, let your system rest. What else do I have on here? Is it okay to do a partial workout or should you always do a full workout? What do you think? Like I always, let's say I'm going to go grab a drink from the garage or something. And I'm like, Cass is like, why isn't he back? It's been like 15, 20 minutes. And it's because I get a little quick set in or something.
Yeah.
And is that good to do? Or do you think you should really just sit, like get a good full workout in?
No, I think 100% it's your lifestyle habits over time. I think partial workouts are way better.
Partial workouts.
Been doing nothing.
But the reality is, it's like time under the curve. You know what I mean?
Sure.
And so sometimes I'll work out between cases if I have a delay. Sometimes I'll work out on my lunch break if I can. So bottom line is move.
Mm-hmm.
Move.
Yeah, I've been going for walks every morning. Just take my dog out for a walk, and that helps me just get up and do something I wasn't going to do.
Oh, one last thing I just wanted to tell you about was we talked about fasting, right?
I think we talked about everything pretty much.
One thing that is another opportunity to put on, help put on muscle is taking casein protein at night.
Yes, I've been hearing a lot more about that. They say 40 grams, right? 40 grams at night. Is that true?
So casein has been something like
it's a slower digesting milk protein.
So casein is. I mean, some people don't like whey. There are issues with whey. I think there are some inflammatory problems with whey.
Oh yeah.
So I do.
That's true. I feel a little bubbly sometimes.
So there are some issues. On the flip side, though, having a slow breaking down protein like casein or putting a little bit of fat at night. Now, people say eating at night is bad. If you're eating a lot of sugar and carbs at night, I don't think that's great. But I do think actually having a slow breaking down protein like whey is beneficial because while you're sleeping, I mean, that's when your body is actually
not breaking
healing.
down. You want it to give it something to
your body is healing.
Build it up.
Your body, that's your restorative time.
Mm-hmm.
Like we're designed to heal our memory, our muscles, all that regenerative time is during sleep. So if I can, I actually try to get a casein protein or some kind of fatty protein, fat with my protein at night. Not you don't need a lot, but if you get like 40 grams of casein is great because it's a slow breakdown.
Mm-hmm.
And so going into sleep, it's like you want to set yourself up for repair. And so I think that's another good idea. That's the disadvantage of, I guess, fasting for a couple of days, And so mentally, I've always known that. That's why I didn't like going to sleep fasted, because I'm like, I'm breaking down.
You feel like you're more broken down maybe by the morning.
And if you've done fasting, especially overnight, like
because I like to eat dinner even when I'm fasting. I don't like to go into the night fasting.
But I mean, if you know your body well enough, sometimes if I go for a fast or you haven't ate for a day, like the next day you feel that you're tighter.
When you fasted.
Yeah.
Yeah, I think so.
Oh yeah. I mean, if you've been up for a day and
yeah, a little more wired, huh?
No, I'm just saying.
But you're wired.
But you're also tighter. But I think you lost muscle. You lost some water. But you've also your tissues are depleted.
Right. Yeah,
you're depleted.
Mm-hmm. Maybe even do you feel like you get dehydrated, or do you take salt with your water?
I have a whole concoction that I do for electrolytes.
When you're fasting?
I do it in the mornings.
Or just in the morning?
I do it in the mornings. I do it every morning.
Did you ever do bodybuilding?
Just for fun.
Like amateur
As
stuff? Or did you ever, a lifestyle, but never competition?
No.
Okay.
I mean,
he could have.
Because some people
go
go for the show. Of course, yeah. I've seen pictures.
He's only 2 weeks away at any given point.
2 weeks away? That's all it takes? All right.
Always just 2
Pump
weeks.
it up like this. But no, just because, especially when you're going to go for a performance or a show, you're really balancing your electrolytes well and, to get the pop of all the different veins and stuff like that. Because bodybuilders know electrolyte balance pretty well.
Himalayan sea salt and cream of tartar because it has potassium.
And apple cider vinegar.
You rub it under your eyes?
No, you just put it in your water in the morning. Lemon juice,
yeah,
cream of tartar, like a little powder of it, sea salt, and apple cider vinegar.
That's the mix. So big cream of tartar has potassium.
Okay.
It's a high potassium, and Himalayan sea salt is very close to kind of the electrolytes that you want with the combination.
Real Himalayan sea salt, right?
Mm-hmm.
There's like fake Himalayan sea salt. I'm learning. You need like the rock stuff.
The rock, you gotta crush it.
Yeah,
that's right.
Yeah.
So, and then cream of tartar. That's the other thing. You should, if you're gonna fast, because it has potassium.
Okay. All right. Well, I'm learning that.
Less calories than eating banana in the morning.
Yeah. I tried to just eat like maybe half a banana. There's so much I
This way,
learned
it's still
from
fasting this way.
Yeah, it's
I
like
can't tell you everything in one shot.
I'm learning all the good stuff today. I'm trying to get it all out of you while I can. All the tips, all the good tips. Well, that's pretty much all I want to talk to you about. Can you examine my shoulder now?
Okay.
Should I do PRP on my shoulder or stem cells?
So
What do
you
you
should
think?
you should even say the word stem cells because we got to be
I like
more
saying it,
specific.
though. It sounds
I know,
cool.
I know, it's not, but we got to be like.
I want to say I do stem cells, so
I
I
know,
say
I
stem
know.
cells.
I don't think we can even.
What is BMAC?
I don't think we can even.
Have to
Say
explain
No,
it.
we know a place in the Bahamas. You
I don't
can
think
go
we
there.
can even say stem cells legally.
Oh, really?
You can't put on your website that you use stem cells.
But they're stem cells.
I think that it's like they'll take.
They
down
are
your-
stem cells.
They'll take down your Google website.
Really?
Peptides, they might too. Certain words, they highly regulate.
I'll look into that.
So
But autologous, like BMAC, has stem cells in it.
yes, no,
So,
I'm just messing.
stem
But,
cells.
but,
no, I mean that's the kind of stuff I.
but I'm saying it's
know.
gotten a bad rap because of its abuse, right?
Right. It's about the indication.
It's about the indications,
Mm-hmm.
and some people are they're calling things stem cells that are not really,
Yeah.
and I think so. For me, the takeaway is autologous. Use your own tissue.
Sure.
That way you're safe.
Right.
That's number one.
Yeah.
Autologous. Number two,
That means the receptors understand your body.
They're you.
It's the same
yeah.
thing. The cells are the same. They're different types of
Yeah.
cells, and then they should have lineages that then respond to your own body cells.
Yeah.
The problem with allogenic tissue is that the cell receptors are different, and the proteins are just a little different. And even though they're all called the same thing, they might have a little different shape, and they have a different effect, and they might have tumor potential.
Yeah.
That's really the big risk. There's a lot less risk, even theoretically, if not, I know obviously there's not enough studies on this to show, but if you're using your own tissue, theoretical risk is extremely low. The only thing I've had problems with or potential where I've said, hey, let's stop, pause before we do something like BMAC is somebody who's had a history of lymphoma.
That's right.
Yeah,
that's right. That's when you want to stop.
Yeah.
So, in my practice, for me, whether it's PRP or BMAC, I think always autologous, obviously.
Yeah.
And the other thing is ultrasound guided.
I do. Pretty much all my injections ultrasound guided, but those make sense to do ultrasound guided. The other thing that I did was really cool is nanoscope guided. So I could see it with the nanoscope
Awesome.
camera. And then you put the needle in right
Yep.
where the tear is. I have some cool pictures.
That's great.
I'll show them after this because I don't want to show them on here. But partial thickness anterior subcable tear. So it's like a crescent, but not a full true cable tear. In somebody in their 50s
What
and
do you
their
use, PRP,
stem cells.
BMAC?
Not stem cells. BMAC, yeah, with the muse cells and all that stuff. Because that's what we're juicing in there.
Yeah,
We're
no, I'm
juicing
with
in
you.
the good stuff.
I'm with you.
Juice it in there. Juice in that good stuff. And then we hope it heals. But these cool muse cells should home to the area. And maybe actually, because when I ask people like surgeons about BMAC, we all use it. It's like, hey, does it work? We all say, yeah, it does work. And then we all know it depends on the indication. So that means it needs to be studied more. But something that is working, that we know is working, we should study more and potentially regulate it based on indication. So we're not just saying it works for everything. It's kind of like PRP. It doesn't work for everything, but it can work really well for certain indications.
And I think how you put it in, right, using ultrasound or using a nanoscope, and then also making sure it stays there. This is why I'm really
Targeted.
excited about that, using the technique that I was showing you with intraosseous.
Yeah, tell me more about that.
No, the
What-
biofertilization.
It's called biofertilization. So tell me about that technique.
So, it's really a protocol. I call it biofertilization protocol, and this applies to really any orthopedic surgical procedure, whether it's biceps, pec, rotator cuff, ACL. The issue that we see in all of this is that the tendon and bone junction. This is where we need to get.
That's what we call the enthesis.
The
Right?
enthesis, right? The enthesis, right? And so, in order to get that to heal, we need obviously the mechanical fixation. I think we're tapped out on that. We're like anchors, sutures; those are so strong.
Yes, repair strong.
We're good.
At the end of the case, I just move the shoulder like this just
We're
to show
good.
you how strong it is. I'm like, that's
All
not
day.
where it's failing.
I'm very confident
Yeah.
in our mechanical
Time
fixation.
zero, it's strong.
Money.
Yeah.
We're good with that, right? So now we got to optimize the soil. This is where I call it fertilization. So this technique really starts before the surgery. It starts with the metabolic report card, looking to see how fertile are you? How good is your soil? Where
Healing potential.
healing
right?
potential,
Yeah.
right? Your healing potential, right? from an intrinsic metabolic side, not the tendon size or the age of the patient. This is kind of the next level of looking at what can we do to get the patients to heal. And these are all modifiable, right? So the things that we talked about, right? So that starts with that, checking the metabolic report card, optimizing the patient before surgery. Then, whether it means bringing in vitamin D, using XR, amino acids, whatever supplement you want to use to get that side. And then during surgery, how can we leverage the body's own tissue? This is where I think the bone marrow aspirate concentrate to capture some of those mesenchymal stem cells, catching those, those tissue growth factors is going to help. So the growth factors are going to send the signal, but you still need the building blocks. This is where some of the kind of the newer type of, I don't say newer, but nuanced use of the PRP, using the leukocyte-rich and higher concentration of some of those monocytes and some of those factors that we typically would maybe throw away. I'm now using that. And then how we deliver it.
You're using it separately? Or using it combined?
I'm combining them. This is stuff that I'm learning from Luga. He's non-operative, but now we're applying what he's learned to improve the surgical side.
The yield.
The yield. So now I want it to stay there. So now we're taking for the rotator cuff, for example. So I'll take the patient's PRP, leukocyte rich, with and this is a platelet rich, leukocyte rich PRP. Mix that with the BMAC along with some demineralized bone matrix. Then we make a putty.
Right.
And then at the time of the surgery.
So that was that technique you were showing me with the inside the bone.
That's right.
I see.
So
okay.
it's intraosseous. So it's intraosseous. And that's what we learned from Dr. Hernigue, who's been doing, the using BMAC for many years.
Sure.
Right. But no one's really kind of putting it really together.
Well, volume is the major issue because I had a plastic surgeon on one of my shows, Dan Gould. I think it was episode 4, maybe right before yours, episode 3, or episode 4. And he was talking about the fact that it's not about how many cells you have; it's how much volume you can fill. Because if you're half full, you have the best cells in the world, but they're down here. How are those going to cross that barrier to fill and heal all around them? So it's about what's around all the cells in this full environment. So if he's going to do a fat transfer for stem cells, say for some type of cosmetic procedure, he needs to make sure that area has good cells, but that the volume that he actually harvest will fill that volume, fill that space, so that those cells have some type of stroma to work around and some type of structure that they can work through. And so it's the same kind of concept.
For us, we're very limited with the amount of space that we have in a lot of the procedures that we use for, a lot of times we're using this for meniscus work or intraosseous issues,
big volume spaces.
Right. So, but sometimes we don't have that much volume. The junction between the rotator cuff and the enthesis is not that much.
Very small.
Right.
Yeah.
So then this is, for me, what makes sense is coming in intraosseous and creating those drill holes at the tuberosity.
Right, so you're not
site.
In that giant area where everything's just washed out.
That's right.
You're
that's
in a specific volume, specific size.
That's what was exciting to show you when we put the
dye. Like containment. That's
exactly
the major
right.
issue is containment.
We put that dye in so we can see where it goes and where it ends up. And what's nice is that when you put that in, and that other x-ray that I showed you was in the recovery room.
Yeah.
That patient in the recovery room, an hour after the surgery, that is contained.
This one?
Yep, that's right. So now that that one is contained.
Yeah.
All the stem cells, the BMAC combo.
In those dark areas, right?
That's all dye. That's put into the tuberosity and right under the rotator cuff repair.
Yeah, that's right where it needs to be.
That's exactly where it needs
Lesser
to be.
Lesser tuberosity and greater tuberosity.
That's exactly where I put it.
And that's pretty cool.
So I'm excited to follow up on that. And this is where, this is our duty to take what we see in the basic science is mu cells that you brought up. Very exciting to see.
Yeah.
But now it's our job to take that, translate it into clinical practice, and then apply it in a way that, is going to have some meaningful differences.
Yeah. Well, what does Gus think about this stuff? Like, what does he think about the...
Gus loves it. I mean, it's been great. I've been very fortunate to have...
Because he's right in there. He's figuring out which cells are doing what.
Gus is the man. And this is why. So he's been super excited because he's like, look, he's like, I've found something that's been very helpful, but getting it to stay there has been a problem. So he's excited about this, and he's also very excited about the nutritional side. He's a huge fan of XR. He's been using it for his patients, and so this is the study that we're doing now. We're looking at the patients that.
Well, he talked about it at the Miami course, and it's been a lot
he
more
talked about
present
Anna.
at the meeting, at the shoulder meeting.
He talked about it at Anna, which is great, and I think
and at AOSSM too.
Yeah, it's becoming something that I think he's also realizing. As much as we may have the matrix, right? We may have the growth factors. You still need the building blocks.
Yeah.
Right. So I call it the bricks and the brick layers. The growth factors, the stem cells, or the brick layers. They will give you the signal, but you still need the actual bricks. And this is where you have a deficit unless you're given that at the right time, the right dose. This is where I think we're getting closer to kind of achieving the better healing rates.
So what do you think about scaffolds? Do you think scaffolds are something that, I mean, there's surgical scaffolds where we have, something like a BioBrace. I'm going to go visit those guys, ConMed. They have the BioBrace device, which is really cool. It's a polylactic.
I've used that.
Biodegradable device.
I think it's all about indications. I think if you have a full thickness rotator cuff tear on a young patient that's an acute tear and all the tissue looks good, I think you're less likely to need some kind of scaffold than someone who's older, degenerative tear with long-standing retraction. I think with tissue loss, with some of the tissue left under the tuberosity, that's a very different rotator cuff tear.
Sure, it's surgical.
Right, and so I think in that case, you know your indications, you know how much tissue loss that you have.
Yeah.
And so, I've used all the different types of patches. So I call it actually, we talked about this called feeding the patch, where these amino acids have the ability to actually improve collagen synthesis.
Yes.
So I think
so like getting those scaffolds, getting the stuff that's needed for healing, those either cofactors or those actual cells or the signaling molecules, so they can get to the area and home to the area where they're needed, and then set up a structure.
So I'll tell you, this was a study done in 2002. Juven was really built on this one study.
Plastic surgeons use Juven.
So I used to use Juven. I used to use Juven. That was one of my products that I recommended.
It's great for wound healing.
It was great for wound healing. So that study was done on 70-year-old women. They were not surgical patients. They were not rotator cuff tears. They were 70-year-old women, 2 groups. They took these catheters that were scaffolds. They stuck it in their deltoid for 2 weeks. They gave them either the amino acids combination that was in Juven versus some non-essential amino acids. The women that got the supplementation, the specialized amino acid, had 67% more collagen synthesis in just 2 weeks. So your question about scaffold, I think scaffold is really important, but scaffold alone is only going to do so much. It still needs to be fed.
Yeah.
So I used to use Juven, but then Juven didn't have all the other stuff that we talked about. I said, hey, Juven is great for like wound healing, for plastic surgeons. I said, I actually called that, but I said, look, this is a great product. I've been using it, but you're missing X, Y, and Z. What's going on? And they're like, well, we shifted over to COVID, and we're looking at different stuff. So bottom line is that we've been using supplementation for a long time. Orthopedics is just new, and I think and this is kind of where
plastic surgery's ahead of us with that
for sure, and because they have that we were looking from on the outside. So I think Juven is great. And I was using it for a long time, but it was missing a lot of things that we also want as orthopedic surgeons.
They're also a lot more critical about their wounds and about their tissue healing. They're just
the patients are very surface level too, so they're also not as muscle focused. They're really, they're looking at the wound, at the scar, at the skin.
Yeah. They're very superficial people.
Which is
no, but our wound. I mean, look, we're talking about our wound being the
I know them.
enthesis.
They're friends. I'm friends with them. As I'm sure you are.
Yeah.
But we're talking about the wound at the enthesis, right?
And I mean that objective.
Yes, I understand.
Superficial. They have deep souls. Dan does, at least. He's a good friend of mine. So what do you think about injectable scaffolds? Do you think there's a need for that in orthopedics? Injectable scaffolds for orthobiologics?
I think it's all, again, tissue dependent, right? Case dependent. I think if we're missing tissue, right? If you're missing tissue.
Yeah, but do you think that an injectable scaffold would be something that would be beneficial to the whole BMAC or biologics realm, where you could inject something that will be a scaffold that will then allow those cells to then ingrow better? Because otherwise you're just relying on these Muse cells, hopefully this theoretical actual
you know,
thing that we're measuring.
I
You like to
think-
go to where it's supposed to go. But what if you could make something say, hey, this is the structure, we're going to print it or whatever, or have some kind of lattice structure that we can inject?
I think there's still
Is
a lot
is there
for
a
us.
field for that maybe?
Yeah, I think there's still a lot for us to learn. I don't know the answers, but I can tell you.
Sounds cool at least.
I think the idea of it makes sense. This is why I like Luca Podesta and Peter Everett's work, where they've taken PRP, but they've added a protein matrix to it.
Yes. I wanted to talk about platelet-rich fibrin. That's kind of similar to that.
Well, that's
The matrix.
So that's
is that what it is?
That's what we're using.
Platelet-rich fibrin.
That's right. So you're
So it's like a thrombin.
you're modifying the PRP to include it to be a protein rich. I'll send you the article. It's a protein rich PRP.
Yeah, send me that because I'll put it on here so that we can look at that. So protein rich, and fibrin rich, so that it can form this kind of gel layer and then hold the good stuff in there for healing. That's theoretical.
So
right?
the biofertilization technique that I'm talking about.
Sure, that's a similar concept.
So that's it. So I'm using. So I pulled in all.
That's the scaffold.
It is.
It just depends on where you put it.
Scaffold.
It's injectable. So to your point, you're asking me about. In a way, I'm like, we're doing it now.
Mm-hmm.
And you have the scaffold within the proteins that are in whole blood.
So
that you were dumping
without it needing to be something synthetic and not,
I'm more.
Have you looked at how that scaffold adsorbs cellular or the exosomes? Did you already say that? Did you look at that? Like, are you able to see what the cellular concentration for that specific scaffold that you're using? Were you able to, like, how did you select that particular scaffold?
I would leave that to Peter Everett and Luga to answer that question because I think they've really defined the concentrations. They have a very specific protocol for if they're looking at your knee, for example, meniscus, and articular space, and they have a very specific protocol. This is what I'm trying to do now, learning now,
But that's why I think scaffolds are so important, because you might have time 0, say this, and then a week later, one group of the scaffold might have all kinds of cellular uptake versus something without a scaffold, and it might be less. I mean, that's the idea behind scaffolds, that we can increase the yield, not just at time 0, but then over time to give it some kind of cellular structure.
I'll send you the article,
absorb
but they specifically comment on the ability of these scaffolds working over time, not just at time 0.
Yeah.
So,
because surgery is really cool. I love the fact that we do surgery, and it's amazing to be a surgeon. But like my neighbors, I was just talking to them, and they're like, "So you're a surgeon?" They're like, "Well, then how could you work remotely? What do you mean?" It's like, yeah, well, I do a lot more than just surgery. So there's a lot of different things in realms of that. But surgery takes us being there, and then having that interaction, and then that, scoping it or opening it and having this, mechanical involvement with whatever we're doing. And it's great because you have to be able to do that. But that's why surgeons, we're the last stop. Like a revision surgeon is the last stop. And then somebody who's a world famous revision surgeon is the ultimate last stop for what we're capable of as humans to help other people. Right. But there's something there where, what you're capable of doing versus what, you can do to actually help somebody with regards to like what types of treatments will actually stimulate that type of effect. That's where we really come in, is we are advising people on, this is what you should do. You might have to take it this far. We might got to drill in your hip, and we got to open things up. But the cool thing is, if we can understand it in such a way that we're getting that effect without the surgery, without the taking it down, without the, the whole open scaffold, but I can inject something because I know, I can see it, I can diagnose it. We have the right
especially
scan.
for a partial tear.
Exactly. Partial tears or something that's not fully structural where we have to be a surgeon.
Well, I'll tell you, some of these guys are showing me some cases that it's almost hard to believe, but some of these full thickness tears that they're putting in fat.
That's where I'm like,
well, I think,
it may be a fibrosis bridge. It's like those structural cables and fibers are just, we're not understanding. We might see, like Joe Rogan talks about how his rotator cuff heals his full length, whatever the hell that means. But it's like,
you've gone back on a re-tear, and there's this pseudo tendon.
There's always tissue there.
I go back on these revision quad tendon.
Yeah, you could image it and you see a connection. You're like, it's healed.
It's garbage.
It's garbage.
Yeah. And so,
I mean, I'm not saying his is, but it could be one of those things where it's like, it's just filling in, so it doesn't mean. That's why when I think stem cells, I'm like, bullshit, right? It's like, no, what I'm using is for a specific indication, and I'm going to be studying the outcomes of how my patients are doing and seeing if they're having an effect or not. Because if they're getting weaker and I get another scan on them, then they have a bigger tear despite the treatment, that means it's not having the effect that I want. So then we got to go to surgery. We got to go to something that's effective. So we're looking at what are the effective treatments, not just what are the treatments. That's why Kim Kardashian got this or this person is like, okay, but what are the effective treatments? What works? And that's why patients come to us as a specialist, because the things that I recommend work.
I totally agree with you. And I think, it's important for us to, do what's right, stick to our indications, but also be open-minded to know that what are our limitations. We can fix, but we can't always heal everything. And this is a very exciting time that we can use things like the body's own tissue, nutrition, and all
because healing, now we can play with healing a little bit. And whereas for a long time, Galen's time, I have this book on medical history. I love medical history. Galen and all these guys who were figuring things out. Like Galen was the smartest guy around, so they're just like, okay, well, I guess he's not killing people as much as the other doctors are, so let's listen to him. Yeah. So then, but Galen was like all about humors and sucking the body's evil spirits out and stuff. But he had some kind of like benefits
even
to
blood.
his treatments. Bloodletting.
He talked about blood for a long time. Galen was one of the first to talk about the importance of blood and the energy in blood. So
right. But there was something there. He's a smart guy. But you can just, you got. It's all about progressing the field, and if you just look at what healthcare was during Galen's time, it's just like avoiding, if we can just avoid all the bad things just a little bit, just like try to have less amputations and less sudden instant death and all these things, then you're getting improvement. You're like, okay, well then if we're improving by causing less harm by our interventions, now how do we get from the 90th percentile to the 95th to the 96th? And then those little increments, they take a lot more work to get there, right? Because way back then you're just like, okay, I'm just gonna not saw his leg off, and kill him to death through amputation, because then they're like, oh yeah, well, I guess he's gonna bleed to death, and now we understand all the bad stuff's out. But it's just that like knowledge of understanding. We've come a long way. We're just getting better at understanding humans and treating humans. It's really what it is. It's like biological tissue, but like we're complex. We're different than dogs and cats. Our tissues are very similar, but because we have those brains and our behavior, it changes all of that. It changes our muscle and it changes our injury patterns.
Well, I think we're at a time now where surgeons, we're now not just being technicians, but we're also thinking about the tissue and the biology. And so it's exciting because we're able to bring a lot of these subspecialties together to the forefront.
Major shifts, antibiotics, penicillin, these are major shifts. You stumbled. I mean, this is like a major shift in our understanding of like healing potential. It's stuff like you're working on. I mean, it's big time stuff. It's really, really cool stuff. And the more that comes out, the more answers, or the more questions come up.
I have
like
way more questions.
More questions. And more like, hey, how do we even get this better?
That's right.
It's really cool.
This is where this whole thing started out with, just maybe the nutritional side, with this metabolic side, and talking about hormones now and looking at all these different variables that come into play, and then how this kind of ties into orthobiologics and using that. And I think this is where us going forward is this comprehensive approach. And I think this is where it's going to be exciting.
Well, keep going, man. I swear, just keep going, because like the world, we need more people like you with all the passion, the energy, the interest, the knowledge and understanding. But like to put it together, to come on my show, you've been here twice now. So it means you like me a little bit.
A team effort,
you like coming on and talking,
fun,
because this means a lot to me.
It's just the tequila, really.
Mandala tequila, we'll be here. But it's like I get a chance to learn. I've learned a lot on this show. Just already, I've learned a lot from you, but then I've had time to kind of process that stuff and then use it and kind of think about what makes sense to me. But then going back and then really seeing other people doing it too, and then it's like, it's not just me drinking the Kool-Aid, because it sounds like it, it can sound like it. But like when you find something powerful, like a good product, then you can start to use it. And then if it's something that really is a powerful product, it's going to, like, time will tell, time tests things, like the shoulder implants I use, the longer you test them, the more they kind of hold up. Right. And so like some of the crappier implants, things that don't hold up as well, it just shows, because time will always show these things. And so I just think it's such a cool thing that you've been a part of. And I feel fortunate to be your friend and to get to know Gray and to kind of, really uncover some of these special secrets. I kind of find it's like a special secret that I know these cool things, that I have cool, smart friends like you. And that's kind of what I'm trying to share with everybody is
Feels
the
mutual, man.
stuff to help people.
Yeah, I think just as much as everybody's getting more specialized in your field and what you do as a shoulder specialist, I see the direction of medicine becoming more comprehensive at the same time too.
Yeah.
You know, with AI and technology and ChatGPT and all these things, we're starting to see the bigger picture
Age of
on how
information.
things fit
There's
together.
so much information.
And it's
So it's like seeking
it's
through
a lot of hope for the future
Yeah.
of being able to help people in a bigger way.
See, it's getting through all of that information from people who know what they're talking about, you know, and if you have those products, that there's so many products out there, and there's so many doctors and there's so many surgeons, there's so many people on podcasts telling you this and that, but you know, when you have the right credentials and you have the right experience and you know from the types of treatments that you've done, you've seen the results, then that stuff is powerful.
I'll tell you, it's been definitely a group effort. I'm learning more, you know, from other people as well. And you know,
Just my meetings with you guys too. I mean, I've
for
learned
sure.
a lot.
You know, and it's great to see the consensus on this. You know, we just had this month we had that recent article come out on Orthopedics Today on Helio, just about the impact of nutrition. You know, and it's becoming very, the awareness on this is increasing. So it's great to see that, you know, and I think we're just kind of at the beginning of it.
You had a recently published article on Helio?
Yeah, just a few days ago.
Oh, nice. So this is this it?
Yeah.
Yeah, it just came out yesterday.
Nutrition may be the key to muscle bone health after surgery. So this was something who wrote this article? That's you.
Well, I was one of
I didn't even recognize you. Look how handsome you look there.
Casey Tingle, I
And
think,
Gary
in
took a
Helio,
picture.
she put it together.
Casey
I
Tingle,
did.
but I mean, I'll tell you, the other people who contributed to this article are like powerhouses.
Paul Wishmeyer.
I mean,
right?
Paul Wishmeyer he's the man. He's an anesthesiologist who's really been on critical medicine, and he's been, you know, talking about nutrition
He's
for
from
such
Duke?
a long time. He's from Duke. He's an amazing, incredible person on, you know, advocate for nutrition. You know, Connie Weaver and Dr. Hirsch. I mean, they're incredible. People
She's a
that I've learned
PhD.
from. Oh yeah, that I've learned from. You know, and so it was really awesome to see.
Oh, it's a big article.
It's a huge article, you know, and talking about all the stuff that we talked about today. And
Is this the one you put on LinkedIn that you texted me about?
yes,
Yeah,
This
okay.
was awesome
great.
to
Yeah, it
see
just
that,
came
you know,
out.
and it was great that, you know, seeing just the awareness on this and talking about supplementation.
Oh, that's great. I'll post a link on this so that people listening to the show that want to do
this
some
is-
more reading about it.
and, you know,
this
and-
looks pretty comprehensive. Helio, so it's Orthopedics Today, right? So it's
Yes.
kind of like what's the current up-to-date stuff on
Exactly.
actual orthopedic
Yeah.
surgeons in the field,
That's
not
right.
Yes.
just this weird stuff that some
Yeah.
guys are using. It's the real stuff.
Yeah, it was,
So this is a big article.
it was
Oh, yeah.
amazing to see that because
Yeah.
it was like, you know, really.
Is Tony Romeo?
Yeah,
Is he?
Tony Romeo. I mean, Tony Romeo is a mentor to me. I mean, I've learned so much from him, and he's just like really shifted the
Oh,
way
there you
I
are.
think. I love the way he thinks, and you know, I've learned a lot from him, and this is a great privilege to be, you know, an honor to be, you know, included in this article.
Well, very cool, man. Well, it's been so fun having you.
Always.
What's your Instagram handle? Do you guys have Instagram for XR? It's Xcelerated Recovery.
Yeah,
right?
it's at xcelerated.recovery.com, XCELERATED, so accelerated with the XC.
Yeah, I always type in XR and then I can't. I go to XR, a different website, but it's not the XR one.
It's the accelerated recovery.
Yeah,
Yeah.
XC. So type
With
in
the-
XC.
Yeah.
And do you have
starting with
a
the XC.
do you have a personal Instagram that you use or LinkedIn or anything like that you want to give?
We have LinkedIn Accelerated Recovery as well too, and xrscience.org has more information for products, website, and our team.
Yeah, I would say if anyone's interested in the literature and want to know more about the science, XR Science.
Yeah, that's
Yeah,
xrscience.org, right?
Yeah, xrscience.org. Yeah, a lot of, you know, I work with a lot of, you know, residents and fellows and
That's where you can get the calculator.
everything is there,
Yeah.
right? The educational piece. To me, education is number one for me, you know, and being able to have kind of like a library where these things are accessible.
The recipes for XR.
Yeah,
on there.
yeah,
That's
it's
all
great.
I-
We have healthcare provider resources, patient resources. Recipes are a big one to support patient compliance and ideas.
How can people buy XR if they do they need a prescription from their doctor or can they buy it if they want to get
It's
it as
over
a
the
supplement?
counter right now. Most surgeons that are recommending it carry it directly through their practice, like yourself, so
Right.
you can get it.
Yeah, I
directly
sell it in
through,
my office.
Yeah, you can get it directly through your surgeon. A lot of hospitals have it at their DME on site. xrscience.org is available, as well as Amazon. But the surgical bundles are generally referred through their surgeon.
Are you guys working on any more flavors down the pipeline, or is it top secret?
We have our 3 flavors now. The cranberry lychee will be updated like the others to reduce the sucralose.
Yeah.
And
You're going to roll them out and kind of see how they hit.
Yeah.
The mocha. I love the mocha.
The mocha personally is my favorite.
Yeah.
I drink
I do
that
mocha in the
every
morning and then cranberry lychee at night. That's how I like it.
Oh, yeah. And the unflavored is really popular. So
Yeah,
I
it's
think
growing on me.
We're definitely seeing
I know I was a little sour
really
on
versatile.
it at first, but it's growing on me.
The recipes really help. For
Same with
anybody
the
who's
grape.
interested,
How do you like taking the grape?
I make a smoothie that I call the PB&J smoothie. I have it almost every day at lunch. I freeze red
You just
grapes.
sold me right
Yeah,
now.
no, but we have to-
Grape
she has to make
PB&J
Okay,
is
it's
like-
the
she makes
frozen
She makes it. Yeah,
the frozen
Yeah.
red grapes
That's the
with a
key.
little peanut butter
That's
in there and a banana, almond milk. You put that grape in there.
I just
It's
bought
a-
some almond butter.
Almond butter or peanut butter,
Ah.
and you do it with the frozen grapes.
You sold. I'm going to go have one right now.
Put a little granola on top at the end.
A little crunchy.
yeah, that's good.
You'll be good.
Man, we're going to have a whole
It's
show just
addictive.
on what to eat for snacks, like appropriate snack eating.
We'll do
guys,
a cooking show. We'll do a cooking
yeah,
version.
you know, that was a big question, was like how to take XR, and it's different.
Yeah.
Like the mocha, you can't just take it with water. You got to kind of take them differently. So
Yeah, you know what?
but experiment, right? Like
Experiment, and most people are doing it 3 weeks, twice a day. So either you just mix it with enough water to just get it down and just be done with it, like a shot, you know, like NyQuil, DayQuil, you're
Try it. I
just
try
done.
to enjoy it.
Or if you enjoy it, put it in your hot coffee, make a blended frappuccino, throw it in your protein shake, your favorite fruit smoothie.
Yeah, like an iced coffee, iced mocha.
Yeah.
That's where the mocha one's really
Yeah.
good. I
Yeah.
kind of put ice and
I'm
some
like you.
milk and stuff.
I've even stuck
Yeah.
it in Jello. You know, put it with the unflavored with bone broth, sea salt, and a bunch of lemon juice.
I think that
do
one
it
would
hot.
work too. It's a lemon bone broth.
Yeah, you can make it hot or cold. So the recipes online really help out a lot.
Yeah, on the XR Science website, right? It's XRScience.
XRScience.org.
Well, cool, guys. It's been
Yeah,
so much having
thank you.
Thanks for coming over and spending a long time with me. We did over 3 hours actually. So it's been a really fun one. Hopefully informative. Hopefully
Yeah.
educational.
Yeah, that's fine.
What do you think's next? What do you think's next for the whole supplement pathway? Or do you think there's more of that XR can evolve? Or do you think there's
I can't
other,
s-
maybe
yes, I
other?
can't say,
You can't
but
say.
yes.
That's really top secret.
Yeah.
I know, I
There's
can't
more
say.
coming. Right?
We'll
There is.
continue
Yeah, cool
to
stuff.
dial in to be more comprehensive and to just continue to make it more patient friendly and an easy
Yeah.
standard of care and make it accessible for
I'll tell you my
people.
biggest challenge, and I can't say, but the way our research works, it takes a really, really long time. And so when we know something works in kind of a practical aspect, to be able to have that bear out in the way we like to show it on double-blind, randomized control studies, that takes a
Right.
while.
Right.
And so we kind of have to
And a
kinda-
lot of money usually.
Yeah, and so we have to kind of keep things, under the table until like it's ready, and then we present it. But yeah, there's a lot of great, exciting things coming.
That's
down the
exciting.
pipe. Yeah.
Yeah, like protocols. I think like when, how often. It's just it's exciting time for optimizing healing.
Yeah.
And I think orthopedic surgeons need to be the ones talking about this
I mean,
stuff.
I would say that, beyond just the supplement, I would just say, to the surgeons or even patients who are out there, raise your awareness, ask your doctor to, screen, look for some of these things,
Yeah.
and before you get cut on, say, am I ready for surgery? And look at that metabolic.
It's a good question.
Just-
Do you think
just-
I'm ready for surgery?
Yeah. Am I healthy enough? Or, and just ask.
Yeah, because
them.
I ask it, but if coming from a patient, I would say, yeah, well, why would you think that? What are your concerns? And then let's talk about it. So I think it's a great question to ask your surgeon.
What can I do to improve my outcomes?
yeah, or what can I do to improve or minimize
to get
my
the most
risks?
out of my surgery?
Yeah, who wouldn't want to do that?
You
Well, keep listening to the show,
Yeah.
guys. And
Yeah.
you're going to get all the tips here on the LA Shoulder Podcast.
Thanks,
Thanks,
Doc.
All right, guys.
Thanks, man.
That's all, folks. Thanks for coming on, Gray.